Hi guys, welcome back. Let me get this synced again. There we go. All right. I hope your dinner was good. Hope you didn't miss me too much during that hour. We got a couple more hours to go, and I'll carry you guys along. So just sit back, relax, let Big John do all the work. I'll carry you guys. Pasta. Ooh, nice. Hi everybody. Yeah, it's like deja vu all over again. It's like I just saw you guys. All right. Now we're up to an important one here. A growth hormone producing. These are very testable. Frozen dinner. Ooh. All right, those could be good. All right, now for growth hormone producing adenoma, it's going to make a lot of growth hormone, but it's not the growth hormone that mediates most of the growth. It's going to be the somatostatin C, which is insulin-like growth factor 1. So let's repeat. The tumor makes growth hormone. The liver and other tissues are now going to produce a lot of insulin-like growth factor 1, which mediates the majority of the growth. Now, when you get the tumor, it depends on what age you're at. If you're young, like a child before your growth plates have fused, well, you're going to become a giant. We call it a pituitary gigantism. Yeah, it's going to be a pituitary giant. Now, what if you're older and you get this tumor? Well, if the growth plates have fused, all you can grow is your hands, your feet, your head. So we call this acromegaly. Acromegaly. You get this flat, broad forehead, like in this picture. Look at this flat, broad forehead. You get big hands and feet. So they're going to say, my gloves don't fit, the rings don't fit, my shoes don't fit, my hat don't fit. These are all the classic things. The extremities are growing. Now, unfortunately, the internal organs also grow as well. So you tend to get very large hearts, and eventually the hearts fail. That's a major cause of death, heart failure. Now, another problem that you need to know is these tumors tend to be very large. Since growth occurs slowly over time, these tumors, you're not going to notice the changes for a long time, and these tumors will get very large. These are called macroadenomas. Well, if you remember, right by the sella turcica, here's the pituitary, right crossing above it was the optic chiasm. So as these tumors grow, they can grow up and knock out the chiasm. So these patients often get bitemporal hemianopsias. So they lose their peripheral vision. So therefore they get in a lot of car accidents. Very common to get in car accidents because you can't see things coming from the periphery. All right, now in addition, they tend to have high sugar. High sugar. The growth hormone interferes with the insulin. They get high sugars. So that's another characteristic feature. High sugars, my hands and feet get bigger, and my gloves don't fit, my hat doesn't fit, my shoes don't fit, and don't forget about the visual field defects. Now, can anybody tell me how you're going to treat this tumor? Well, again, transsphenoidal resection. We'll come in transsphenoidally and resect it. Very good. Is there a drug that we can use if it's unresectable? Excellent. A somatostatin analog like octreotide can be used. Very good, Varshini. Excellent. So transsphenoidal resection and octreotide, two of the things we can use for these tumors. All right, now what about Sheehan syndrome? Well, if you remember, during pregnancy, here's the pituitary gland. Now, the anterior pituitary has its own blood supply. Posterior's got its own as well. Posterior's got its own. Now, during pregnancy, the adenohypothesis basically doubles in size. It got twice as big, but its blood supply stays about the same. Blood supply didn't change. See that? Same blood supply, but much larger adenohypothesis. So unfortunately, it's kind of like borderline ischemic. Yeah, borderline. So if there's significant hemorrhage at the time of delivery, I'm talking significant where you get hypotensive type. If you get hypotension, this anterior pituitary will now get ischemic and literally die. Not the posterior. Posterior's got its own blood supply, but its anterior is now going to die. So this is called postpartum pituitary necrosis. And now the entire anterior hypothesis hormones will be missing. So you'll be missing growth hormone, not going to grow. You'll be missing ACTH, adrenals are not going to work. You're going to be missing TSH, you're going to get hypothyroid. You're going to be missing LH, and FSH. So now your gonads are going to fail, FSH, LH. But the one that will be most obvious immediately is prolactin. Prolactin. Without prolactin, this mother is not going to be able to breastfeed her baby. So that's your earliest clue here. Failure to lactate after the delivery. That's the earliest clue. And then of course, you'll start getting hypothyroid, and your adrenal will fail, and your gonads will fail. Basically, everything starts failing. But the first clue is failure to lactate. Now, clearly, we're going to have to replace all these hormones because the anterior pituitary is basically infarcted. Posterior is fine. Oh, which reminds me, what comes from the posterior? What comes from the posterior? The neurohypothesis. Oxytocin, ADH. Good news, there's no diseases of oxytocin, none. But there are two diseases of ADH. We have either a deficiency where it's low, or we have too much of it in inappropriate secretion. So we have two problems with ADH. They're kind of opposite disorders. Now, for the first one, diabetes insipidus, there's two causes. It could be central, or it could be nephrogenic. Let's do central diabetes insipidus first. Something is going to damage the stalk of the pituitary. So head trauma, a tumor, something damages the stalk. Now ADH can't come down the stalk to the pituitary. So you're going to get an ADH deficiency. Now, I don't like memorizing. I like understanding. Antidiuretic hormone. If you're missing antidiuretic hormone, you're going to diurese. You're going to produce a tremendous amount of hypotonic urine. So basically, you're peeing out water. That's what you're doing. You're peeing out mostly water. So good news is, if you pee out water, you're dehydrated. So what does your body do? It gets thirsty, and you drink it back in. Awesome. So here's the good news. As long as you can drink, no problema. As long as you can drink, you'll always drink enough to equal what you lost. The problem is if they can't drink, if they go unconscious, they get knocked out, they're in a desert, if they can't drink, then they'll get dehydrated. So it will appear that the sodium is high because basically you're dehydrated internally. And this sodium is now going to cause lots of neurologic problems. That's really the key here. When you lose all this free water, your sodium gets really high and it messes with your nerves. That's not good. So the good news is, as long as they can drink, we're okay. If they can't drink, that's when you get problems. So give them an IV, give them fluids real quick. Rehydrate is critical here. Now, for central, again, it's usually due to head trauma or due to tumors. So we'll try to treat that, try to resect the tumor. And head trauma, hopefully it will, over time, it'll get some reconnections and get the ADH coming down again. But again, we can give you replacement ADH. All right, now let's talk about nephrogenic. Nephrogenic means I have the ADH, but the kidneys don't respond. They don't respond. So it's a lack of renal response to ADH. Can anybody name for me two drugs that are notorious for causing nephrogenic diabetes insipidus on a USMLE exam? Lithium is the big one. And lithium, you bet, lithium. The other one is demeclocycline. Demeclocycline. It's an antibiotic that used to be used. Demeclocycline. Okay, so lithium and demeclocycline, two drugs that they know they've used on the exam to give you nephrogenic diabetes insipidus. So for these, you tell them stop the drug. Stop the drug. Okay, for central, you got to tell them, hey, drink, drink, drink. As long as you drink, you're good. So drink or give them fluids IV, get them hydrated. All right, now let's go over here. Syndrome inappropriate ADH creation. Now, why would you make too much ADH? It's usually a tumor. Oh, they love small cell of the lung. Small cell of the lung making ADH. They love that. Now, let's think about this. If there's too much antidiuretic hormone, well, that means you're not going to diurese. You're going to hold on to the water in your body. You're going to make very little urine. It's going to be very concentrated. So, again, you'll have very little urine that's very concentrated. And you're holding on to water. You're holding on to it. So the sodium level is going to appear very low because you're holding on to it. You're basically diluting it. Now, the problem with holding on to water is your brain can't swell very much. And that's a big problem. So brain can't swell, you got trouble here. Not a good thing. So we got to treat this tumor very rapidly to stop this ADH secretion. And tell them water restrict, no water. If they drink water, they're going to hold on to it. So we want to do water restriction here. Don't allow them to drink. There's the new Vaptam drugs. Do you remember the Vaptam drugs? Those are pretty effective here as well. Vaptam. Anything, and there you go. Anything that's with Vaptam. Those are also very cool new pharmacology drugs. Anything new like that, they love the VAP jam drugs. All right, now let's go to craniopharyngioma. I think we talked about this already, but let's just mention it again. It's a benign tumor that occurs near the pituitary. It's not a pituitary tumor, but it's near the pituitary. It arises from Rathke's pouch, which is otogenic or tooth epithelium. It's usually located right above the sella turcica, so suprasellar mass, and it can go downwards and destroy the pituitary. It's the most common cause of panhypopituitism in children. It can go up and knock out the optic chiasm. You get the bitemporal hemianopsy as well, which is like the growth hormone producing one. Okay, very good. All right, now let's switch gears and go to the adrenal gland. Now, Cushing's, we all know about the buffalo hump and the moon face and the abdominal stria and the truncal obesity and the hypertension and the osteoporosis. Oh, which reminds me, the only patient who's obese and has the osteoporosis is Cushing's. Yep. The only person you'll ever see that's obese with osteoporosis. Usually obese patients have estrogen on board and they have good bones. They don't usually have thin bones. So osteoporosis in an obese patient, think about Cushing's. Now, Cushing's, the most common cause of it is us. It's doctors giving too many steroids. That's what it is. Now, the good news is that is not a diagnostic dilemma because we know we're giving you steroids. Now, one thing they could ask is what happens to the adrenal glands? Well, they're going to be really small. They're going to be very atrophic. Because of the cortisol that you're giving, they're going to be really small. So if I suddenly stop the cortisol, what will happen? If I suddenly stop the cortisol, oh yeah, you're going to go into adrenal crisis. You bet. Because the adrenal gland can't suddenly make hormones. It can't make cortisol suddenly. They need time. You have to rev them back up. So that's why we taper steroids. We never stop them suddenly. We have to taper them to allow the atrophic adrenals to grow back to a normal size. Okay, because if you've been on steroids for a while, you're going to shrink your glands. All right, so again, this is not a diagnostic problem because we know we're giving you the hormones. We're giving you the steroids. So the diagnostic problem is pituitary Cushing's versus adrenal Cushing's versus ectopic Cushing's. That's a big differential. Now, first of all, there's 3 tests here. So deep breath. 3 tests. First test is you have to prove this Cushing's. So what are you going to measure? Well, there's high cortisol, so what are you going to measure? Cortisol in the morning, at night. When are you going to order cortisol? Morning, night? Yeah, you got to do it all day long. It's going to change. You got the variation during the day. You don't do it once. You measure 24-hour cortisol, 24-hour urinary cortisol. That will prove you have high cortisol. Right? You can't measure it once. Yeah, good. Can't measure it once. Got to measure it throughout the day by making a 24-hour urine cortisol. Okay, if that's high, we know you have Cushing's. So now we have to find out why. Well, the most common is pituitary, right? A pituitary tumor. It gets its own name. We call it Cushing's disease because it's the most common cause aside from iatrogenic. So this is a tumor of the pituitary, which is making ACTH. So this is clearly going to be high because that's what the tumor is making. Now, what is this going to do to the adrenals? It's going to stimulate them, so they're both going to be enlarged. So we would expect to see 2 large adrenal glands, and that's what's making all the cortisol. Make sense? So what's elevated? ACTH and cortisol. They're both elevated. Good. Now let's compare that to adrenal. Adrenal is a cortical adenoma. The cortical adenoma is making the cortisol. So if the tumor's already making cortisol, what does the pituitary say? It says, I got plenty of cortisol. I don't need to make any more stimulation. So this one, the ACTH goes down. So you're going to have any trouble telling these 2 apart? No problem. Look at this. Pituitary, it's going to be high. Adrenal, it's going to be low. Easy peasy. The trouble comes with ectopic. Ectopic. So like a small cell of the lung or a renal cell carcinoma, if they're making ACTH, notice ACTH is going to be high here. So now I got trouble here between this one and this one. Okay, and this one's easy. This one's easy. But these two can look similar. And don't forget, the ACH is going to stimulate the adrenals to get big, and the adrenals are going to make the cortisol. So it's very similar. This one and this one are kind of like difficult to tell apart. So to tell them apart, we need the dexamethasone suppression test. Now listen closely. It never suppresses except for high dose if it's a pituitary tumor. It's the only time it actually suppresses, when it's high dose and it's a pituitary. Because question, is a small cell of the lung going to respond to dexamethasone? Does a small cell of the lung respond to anything? It's like, it's not going to suppress. Is an adrenal tumor making cortisol going to listen to dexamethasone? No, it's more cortisol. Why would it respond to more cortisol? They'd be like, now, does pituitaries respond to cortisol, dexamethasone? Sure, they're supposed to, but it's a tumor, so it'll only respond to high dose. It won't respond to low dose, it responds to high dose. Because that's what it's supposed to do. It's supposed to have negative feedback on it, right? Cortisol is supposed to give negative feedback on the pituitary. So that makes sense why the only one that would respond to dexamethasone, and it would have to be high dose, is the pituitary. Only one that's going to respond. Make sense? So we only have 3 tests here. That's it. 24-hour urine cortisol to prove you got Cushing's. Then you have either the ACH level or the dexamethasone test. That's it. Only one time dexamethasone ever suppresses is high dose with a pituitary tumor. If ACTH is low, we know it's the adrenal. We know it's the adrenal. So with these 3 tests, we should be able to diagnose these pretty easily. Now, again, we still have to continue our workup. So if it does suppress, we know it's pituitary. So what would you get next? You know it's the pituitary. So what test am I going to do to see the pituitary? Yeah, let's get a CT or MRI. Usually is really good for anatomy in the brain. So MRI, you can get a CT. It's quick. So MRI or CT of the sella turcica. Over here, we're going to definitely take a look at the adrenal. Usually do a CT of the adrenal. And then over here, you're going to do actually a CT of either the lung or the kidney or both. So CT of the lung or the kidney to look for lung or kidney cancer. Make sense? Yeah, and remember, in endocrine, imaging is always last. Imaging is always last. It's a good rule. So when you get on step 2 and step 3 and they say, what is the first step? It's never getting a CT or MRI. Never. Never. Even if they say, doctor, I got palpitations, I'm sweating, I got tachycardia, I think I got a pheo. You still don't do a CT first. You always get biochemical confirmation first for endocrine. Always hormones, right? Always chemicals. So always start with biochemistry first. At the end, you'll localize with a CT or MRI, but never first. If you do CTs on everyone, you'll find a lot of things that you wish you didn't find. Okay, because you'll find incidentalomas and you'll be doing surgery for no reason. So for endocrine organs, we always do biochemical analysis first, then we'll use CT or MRI at the end to localize. Very good. All right, now let's talk more about the adrenal gland. Here's the adrenal gland. If we remember, we got a cortex and a medulla. Here's the medulla. And we got a cortex. Now the cortex, remember the layers? We got G, F, R, right? GFR, the layers. Okay, so glomerulosa, fasciculata, reticularis, right? What does the glomerulosa make? It's going to make us aldosterone, right? Aldosterone. What is the fascicularis going to make? That makes us a cortisol. Cortisol. What does reticularis make? So what's the saying? The deeper you go, the sweeter it is. Salt, sugar, and sex? Absolutely. Absolutely. So if there's a tumor of the adrenal cortex, that tumor could make aldosterone, or the adrenal tumor could make cortisol, or the adrenal tumor could make sex hormones. So if it makes cortisol, we talked about Cushing's, so that was adrenal Cushing's. If it makes aldosterone, that's going to be called primary hyperaldosteronism. Primary because it's the gland that's making it. And another name for this is Conn syndrome. This is adrenal cortical adenoma that's producing aldosterone. So what the tumor is making, aldosterone. Now, remember what aldosterone is going to do. So if aldosterone is high, what's that going to hold on to? It's going to hold on to salt and water, sodium and water. So now you're going to get hypertension. Sodium goes up, water goes up. Oh, but what does it do to potassium? I forgot to ask you. What does it do to potassium? Yeah, it's going to waste the potassium. Now, this is going to give us hypertension, right? Hypertension from the sodium water. Now, when I have hypertension, what's the renin level going to be? Well, if you already have hypertension, do you need renin? And that's what they love to ask. They love to ask about the renin here. So since this is a tumor making aldosterone on its own, it's going to give you hypertension. You don't even need renin anymore. Renin, because of negative feedback, will be low. So again, they love these up arrow, down arrow questions. When you have Conn syndrome, it's a tumor making aldosterone. So you're going to hold on to water, salt and water, and get hypertension. Laboratory is going to show hypokalemia because it wastes it, high aldosterone, and they love the renin. Renin will be low, negative feedback. All right, finally, what if the tumor is making sex hormones? Well, then you're going to get virilized from all those androgens. So this is called the adrenal genital syndrome, which is basically any adrenal disorder that makes you virilize. It affects your genitals. Okay? So any adrenal disorder that has excess production of androgens and creates virilization. Now, the one we just mentioned was an adrenal cortical adenoma, but believe it or not, carcinomas are actually more likely to do it. So adrenal cortical carcinomas are more likely to cause androgens production. Now, another one they like is congenital adrenal hyperplasia. You remember those, right? Congenital adrenal hyperplasia. 21 was the most common, but there was also 17 and 11. Yeah, that's another reason the adrenal can undergo hyperplasia and make androgens. It was mostly 21 and 11. Those are the two that will make you virilize. Good. All right, now the next adrenal diseases are basically adrenal not working. So we got acute insufficiency and we got chronic insufficiency of the cortex. If it's acute, it's often lethal. Acute cortical adrenal insufficiency, it's usually called Waterhouse-Friderichsen syndrome. It's a classic pattern in medicine. You're basically getting bilateral hemorrhagic infarction of the adrenal glands. The reason for this, it's a young adolescent who has Neisseria meningitis and it doesn't get treated. If it's untreated, they will now get septic. So their blood pressure is going to drop and they're going to trigger DIC. Okay, so Neisseria is notorious for triggering DIC. So now look what we have here. We got sepsis, so hypotension, and now we're getting clotting. So you're going to clot the adrenals. So now they're going to infarct. They're going to infarct. So you're going to get bilateral infarction of the adrenals. Okay, and basically the patient dies of adrenal crisis plus septic shock plus DIC. Remember, prognosis for DIC, DIC stands for death is coming. That's what DIC stands for. So between the DIC and the sepsis and the adrenals not working, usually it kills you. So your only chance is to get the pressure up, give antibiotics to kill the infection, and replace the steroids. That's your only chance of survival. Okay, so treat the underlying cause of the DIC by giving antibiotics. Get the fluids up, fluid, pressure, and then replace the steroids from the adrenal. If you do all that, you have a chance. But in my experience, most of these patients are going to die when you get that far. Now, what if you slowly destroy the cortex? Well, you can survive that because it's slow. So I'll know to replace all the hormones for you. So basically, you're going to destroy the cortex and you're going to lose your sex, your salt, and your sugar. Right? So no sugar, no salt, and no sex hormones. They'll all be deficient. We'll have to replace them. Now, this has been a board question. What is the most common cause of Addison's disease? Well, it's called autoimmune. Autoimmune adrenalitis. Most common cause. Your immune system destroying your own gland. Now, in the past, TB used to be a big cause. Obviously, TB is not very common anymore. We don't see much of it as much as we did in the old days before we had good drugs. But now, TB can still do it. It's just less common. And of course, metastatic tumor can do it, especially lung cancer. If you remember, lung has tropism for the adrenals. So it loves to go there and damage them. All right, now how are the patients going to present? Well, you're going to be weak because of cortisol. You're going to get hyperpigmentation. They love that. It's because of the high levels. Without cortisol, the pituitary makes ACTH like crazy. So it's the high ACTH, which has similar properties as melanocyte stimulating hormone. That's why they start getting dark like a movie star. They start getting dark, especially along the crease lines. You'll see hyperpigmentation along the crease lines here because of the similar properties to the monocyte-stimulating hormone. Now, without the aldosterone, you'll get hypotension, and of course, the sugar, you're going to have low sugar and a poor response to stress because of cortisol. Loss of libido, that's obviously due to the sex steroids. Treatment, let's replace your salt, your sex, and your salt, your sex, and your sugar. Makes sense, right? And what president was kind of dark? He's kind of like a movie star. He was dark, and we think had Addison's disease. Actually, we know he had Addison's disease. Which president? Dark, movie star-like, starts with a J, ends with an FK. JFK, yeah, he had Addison's disease. And by the way, he was our president during the Bay of Pigs invasion, where we made a mistake and we decided to invade Cuba. Yeah, so this guy had poor response to stress. That might have interfered with his ability to make good decisions there, because we almost went to World War III. Almost had World War III with Russia because of Cuba. Very interesting. Yeah, but clearly, I think he was being treated well, right? I think he was being treated well. I think they gave him plenty of replacement, okay? Because him and Marilyn were all over the place. So I think he was being treated okay. Right? Yeah, supposedly, yes. Very good. All right, now what about pheochromocytomas? These are a board favorite. Pheochromocytoma, dark, dusky colored tumor. Remember, the adrenal medulla is kind of red-brown, and these tumors are red-brown as well. Now, they're not common, but they happen all the time on USMLEs. It's one of those things where the exam asks it way more than you actually see it. But we'll nail it. Now, it's mostly a benign tumor of the adrenal medulla, and it produces catecholamines, so epinephrine, norepinephrine. Now, what's this going to do to you? It's going to give you a headache, episodes of tachycardia, palpitations, sweating, anxiety, episodes of hypertension. Tends to be episodic in most cases. Okay, now there's a rule of tens. 10% occur in children. That means mostly it's adults. 10% are bilateral. That means mostly it's unilateral. 10% occur outside the adrenal. That means mostly it's in the adrenal. 10% are malignant. That means mostly it's benign. And then this 10% is not 10%. This 10% is 25%. 25% are familial. Familial. So you look for MEN 2A, 2B, 2 or 3, however you like to call them, 25%. So it's very important. When you see a pheo, you got to check calcitonin. Why do I check calcitonin? Because if calcitonin's high, that means they got medullary, and medullary will kill. Medullary will kill. So you got to make sure you check calcitonin. See if it's genetic or it's just sporadic. All right, so rule 10s. Now, can you tell me if it's outside the adrenal, what do they call a pheo when it's outside the adrenal? What's the name for a pheo when it's outside the adrenal and the sympathetic ganglia? Yeah, they call it a paraganglioma. So if you're looking for pheo, because it looks like pheo, it smells like pheo, it looks pheo, VMA and everything, you think it's pheo, you don't see pheo, look for paraganglioma. That's the name of a pheo when it occurs in the sympathetic ganglia. Okay, so remember that name, because 10% will occur outside the adrenal gland, usually in the sympathetic chain, and we give it a different name. We give it a different name. So frustrating. When they give it a different name, they call it paraganglioma. Wish they just call it pheo. Now, to diagnose this, again, we don't just run around doing CTs on everybody. I know you'd love to, but we don't do CTs on everybody. First, we do biochemistry first. So what's the breakdown product of epinephrine, norepinephrine? Well, we're going to look for venomendelic acid. Yeah, but you knew that one. So now you're going to ask about homovenelic acid. So if you know venomendelic acid, they're going to ask about homovenelic acid. Yeah. Or better than that, the best one right now, VMA is not the best, HVA is not the best. What's the best one? Metanephrines. Metanephrines. Look for free metanephrines, either in the urine or the plasma. urine or the plasma. That is best. You can look for all three, but on the exam, if they only want me to pick one, metanephrine is your best. Okay? Now, treatment. We're going to do surgical resection, but I can't take you to surgery with high blood pressure. So what drugs do I start first? What drugs do I start first? Good. So we're going to start the alpha drugs first. Alpha drugs first. Alpha blockers first. So phenoxybenzamine is usually what we do first. Phenoxybenzamine. Then you can add beta second. But first alpha drugs. First alpha drugs. If you add beta first, you'll get unopposed alpha. So alpha first, then you can add beta if alpha is insufficient at controlling the pressure. And look at the name. Phenoxybenzamine. Look. Phi-O. Do you see the Phi-O? See the Phi-O? It's got Phi-O in it. So phenoxy for Phi-O. Phenoxy for Phi-O. So alpha, alpha, alpha first. Alpha first, then beta. But beta first, you get unopposed alpha. So alpha first, then beta. Very good. All right, now we got to finish with the multiple endocrine neoplasia syndromes. Men, 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 men. So question, are men dominant or recessive? Are men dominant or recessive? Umberto. Amjit. Yes. Tamir. Dominant. Yes. Dominant. Dominant. Yes. Yeah. Usually there's a controversy. You guys are kind of cool. And usually it's like women are saying no, no, they're not, and men are like yes, and women are like no, and men are like no, and yeah. Usually it's controversy. You usually have to say, okay, let me just say, do men think that they're dominant or recessive, and then we get agreement. If they think, everyone knows men think they're dominant, right? Whether they are dominant, that's up to opinion, right? Okay, gentlemen, behind every great man is a woman controlling them. You'll see. You'll see. So at least the syndromes think they're dominant. So this is three diseases that are autosomal dominant. At least they think. All right. Now you're going to see hyperplasia and benign, usually adenomas, mostly in endocrine organs. Now you got three of them. You got MEN1, you got MEN2, and MEN3. Unfortunately, they still use the old names. So this is 2A and this is 2B. It's probably better to call it that anyway because they're almost the same. They're like the same. So it's kind of better to call it 2A and 2B. Now let's start with MEN1, also known as Werner's. Werner's, like a worm. Now this is going to have basically three P's. You're going to have a pituitary adenoma, you're going to have a parathyroid adenoma, and you're going to have a pancreatic adenoma as well. Now the pituitary one can make growth hormone or prolactin or ACTH. It can make whatever it wants. The parathyroid one is going to make PTH and you're going to get hypercalcemia. The pancreatic one, well, most common islet cell tumor is going to be a beta cell tumor. It could make insulinoma. But it could also be a G cell tumor. If it's a G cell tumor, that's going to make gastrin. That's going to give us a fourth P called peptic ulcers because of Zollinger-Ellison syndrome. So notice Zollinger-Ellison is associated with MEN1. Yeah, because the third P was a pancreatic adenoma, the islet cell, called a gastrinoma. Gastrinoma. Okay? So gastrinoma, you get peptic ulcers, you get Zollinger-Ellison because the gastrin is so high. Now, good news. The gene for MEN1 is called the MEN1 gene. It makes a protein called menin. So MEN1. MEN1. You can't miss it. Too easy. Not going to ask it. Too easy. They're going to ask 2A versus 2B because they look very similar. That's why they call them the same thing. So what do they both have? They both have medullary carcinoma of the thyroid. And they both have pheochromocytomas. That's what they both have. So we got to make them different. We got to make them different. So here's how we're going to make them different. For MEN2A, we're going to add parathyroid. Either adenomas or hyperplasia, so look for high calcium. Look for kidney stones. Look for calcium trouble. For MEN2B, we're going to add two things. Benign neural tumors like neuromas, neurofibromas, but the one they really like is a ganglioneuroma of the intestine. Ganglioneuroma of GI tract. So they really like. So again, some benign neural tumors somewhere. So neurofibromas in your skin, neuromas in your skin, or ganglioneuromas in your GI tract. Look for benign neuronal tumors. And one more. Do you remember President Lincoln? We think President Lincoln had marfanoid features of MEN2B. Yet he was meant to be. He was meant to be the president. So remember marfanoid. Marfanoid. He was meant to be tall. He was meant to be the president. So that's pretty cool. So which one's got marfanoid features? Meant to be the president. Lincoln. Meant to be. So there's two clues that they can give me. They can give me the neural tumors, or they can give me the marfans, and that will make me pick 2B. Meant to be the president. Now, both of these are similar because they both have the same mutation. They both have mutations in RET. Now, they're different mutations, but they're both in RET. That's why they look so similar. Both have RET mutations. Cool? So again, if I'm asking questions, I'll probably ask about 2A and 2B. Or if I'm going to ask MEN1, I'll ask about the Zollinger-Ellison association or peptic ulcers. I'm going to ask some sort of association. Like if you have a pituitary tumor, what else should I look for? Oh, if you have a pituitary tumor, look for pancreatic tumors and look for parathyroid tumors. Okay, that's kind of stuff they'd ask. Okay, endocrine is covered. So now we got to go to the bones. Time for the bone pathology. Now, in this section, the highest yield is going to be the bone tumors. Bone tumors, bone tumors. Ewing sarcoma, osteogenic sarcoma, those are super high yield. Now, along the way, those are some important things too, like Paget's, osteoporosis, osteomalacia. These are all important things as well. So let's go through them, make sure we don't miss anything important here. Okay, for hereditary, achondroplasia and osteogenesis imperfecta. Okay, let's break it down. A means without. Chondro means cartilage. Plasia, growth. Without cartilage growth. So basically, there's fibrosis in the growth plate and the cartilage can't grow. It's a growth plate problem. So this is the most common form of hereditary dwarfism. Did you guys see follow the yellow brick road, follow the yellow brick road, follow? That was a whole cohort of achondroplasia, if you remember The Wizard of Oz. Do you guys remember Mini-Me? 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 Austin Powers Mini-Me? Achondroplasia. Do you guys remember Game of Thrones? The Imp? Yeah, achondroplasia. Yes, achondroplasia. So when you see dwarfism, the most common form is achondroplasia. Now, there are also variants of it as well, but achondroplasia as the main diagnosis is the most common form of dwarfism. Now, it's autosomal dominant, so you're going to pass this on to half your kids. So genetic counseling and screening. And by the way, do you think one short stature individual might marry another short stature individual? You think that's common? Yeah, they see eye to eye, right? So it's certainly possible. Now, that would be a very high risk of having children with it. So genetic counseling, genetic screening is incredibly important there, okay? Now, what gene are they going to look for when they do genetic counseling? Well, it's a mutation in the fibroblast growth factor receptor number 3. Okay, but it's not knocked out. No. It's actually activated. This is an activating mutation. It's called a gain of function. Gain of function mutation. Those are always cool to ask because most time you mutate, you knock stuff out. So you're going to activate this gene. Now, let's think about this. If you activate the fibroblast growth factor, I think fibroblasts will get activated. I think fibroblasts are going to activate and fibrose the growth plate. They fibrose the growth plate. So now you can't make good cartilage there. That's what they call achondroplasia. The cartilage is going to get all messed up with the fibrosis there. And therefore, you're going to close that bone. That growth plate is going to close early. It's going to close early. So therefore, all the bones that have growth plates are going to be short because you get premature closure of the growth plates. Yeah, so the key is the long bones are going to be short and thick. Short and thick. See that? And that's why they're gonna be dwarfs. They're often very curved as well. Short, thick, and curved. Now the cranial bones are usually relatively normal. The vertebral bones are usually normal. So it's gonna appear like they have really big heads and really big bodies because their extremities are so short. There you go. Look at his head, looks so big. Head looks so big. His arms are so short here. And look at the curve. I think you can see it's curved. Again, very short. See that? Yeah. The lollipop gang, the lollipop gang, the lollipop gang. All right, now what about intelligence? Well, on Game of Thrones, he might be the smartest one in there, although he almost did get killed by his father. But he's pretty darn intelligent. Every time he gets thrown in jail, he winds up being next to the queen, right? Lifespan, normal lifespan unless your father kills you. What else? Oh, reproductive ability. They can easily have kids. Nothing wrong with their reproduction. So basically, just the long bones are short. That's it. Short, long bones. Again, remember, gain of function mutation, and that's what they're going to ask. Gain of function mutation. So you fibrose your growth plates. Okay? Yeah, then he killed his father, right? His father's going to kill him. He said, no, I'm going to beat you to it. Short, thick, and curved. Very good. Okay, now we're going to switch gears and talk about osteogenesis imperfecta. Osteo means bone, genesis means formation. Bone formation is imperfect. Imperfect bone formation. So another name for it is brittle bone disease. If you don't make bones properly, they break. They break like crazy. You're like a China doll. You grab it, pull, you're going to break the kid. Break the kid. Oh, wait a second. If they get lots of fractures of various ages, what is this going to look like? You grab a kid, you pull it, you fracture it. You grab a kid again, pull it, fracture. It's going to look like child abuse. It's going to look like child abuse. So we got to look at this closely. Now, the most cases are dominant, although there are recessive forms as well. This is a hereditary defect leading to abnormal synthesis of type 1 collagen. Remember, your bones are made of collagen type 1. So this is going to make your bones really weak if the procollagen is mutated. They're going to have generalized osteopenia, that means thin bone, because not enough collagen 1, and they're going to get recurrent fractures and skeletal deformities of various ages. Now, it looks like child abuse. What would you look for, by the way, in child abuse? In your eye. What would you look for in the eye in a child abused child? What do you look for in the eye in child abuse? What's in the eye? Yeah, you look for retinal tears, retinal hemorrhages. Shaken babies, you're going to damage the retina. You look for retina. When you go to look for that, you're not going to see it. Instead, you're going to see blue sclera. So you're thinking it's child abuse, then you look in the eye for the retinal tear. No, you're going to see blue sclera instead. So that's a really big clue because the collagen is thin. It's also thin in your skin, so bruising, very easy to bruise as well. So thin sclera, and therefore it creates a blue hue. Blue hue. All right, what else do we have here? The bones in the ear are going to fracture. Remember the middle ear? They're going to fracture, and so you're going to get deafness. It's another important clue here. So they get fractures and deafness. The teeth are bad. They often have bad teeth because that's dentin is made of collagen 1. So they get these yellow, broken, cavity-ridden teeth. Nasty-looking teeth. What else? Their skin is very thin and they bruise easily. Okay, so basically you have to be very careful of these kids not to subject them to any significant stresses because they will break. They'll break. Okay? Yeah. Now, here are the forms of it. We've got dominant forms, we've got recessive forms. Now I need to know which presents early and severe, dominant or recessive? Oh yeah. Always remember, recessive diseases present early and uniform and severely. So if you ever see a disease where the baby's really sick early and dying early, think recessive. Dominant presents later. It's more variable. It's more incomplete penetrance, more variable expressivity, but recessive presents early and severely. So I don't want you to memorize this table because you'll die. I want you to remember if it's recessive, they present early. In fact, in utero, when they go through labor, the uterus contracts and contracts, and the baby goes, and they're born as a crumpled pile of bones. That's the worst form. That's the worst form because you're born dead. So recessive ones are going to be very severe. Now, the dominant ones tend to present much later. They'll have fractures, blue sclera, hearing loss. Again, presents progressively more fractures over time. It's variable. But for recessive, they present early and severe. So that's the one thing I want you to know. I'd want you to know type 2 is recessive, type 2 is the worst. That's it. You know that, you're ready to rock and roll. All right, now the other thing I want you to remember is it's not collagen 1, it's pro collagen 1. That's the problem. It's the pro collagen 1. Okay, so pro collagen type 1, that's what the mutation is in. Good. Samuel L. Jackson in Unbreakable. Yes, he did. The character in Unbreakable. Grey's Anatomy. I didn't see that. Grey's Anatomy, somebody's got it as well? Very interesting. Yeah, I gotta watch Grey's. I gotta get on the I gotta get on Netflix and watch Grey's. I watched like the first few episodes and that was it. Everybody's saying it was good. Now it's terrible. I heard it's no good. Yeah, I gotta catch up. I gotta catch up. All right, now let's talk about this disorder. Osteo means bone. Porosis means well, not porosis, petrosis. Petrosis means stone, like marble. This is thick, dense bone. So I need to know if the bones are thick and dense, why do they fracture? If the bones are thick and dense like stone, why do they fracture? Why do they fracture? Why do they fracture? They get sclerotic, correct? Why? Why are they going to fracture? Because to have strong bones, what do you need? You need remodeling. If you don't remodel your bones all the time, even if they get thick, they'll be weak and they'll fracture. It's like chalk. If you feel chalk, it feels firm. But then you go like this and it snaps in 1 second. So they're firm, but it snaps because it's not being remodeled. It needs to be remodeled all the time. In fact, yeah, I think every molecule in your entire skeleton gets turned over every 5 years. So when your mom says, you're not the same person you were 5 years ago, she ain't kidding. You got a whole new skeleton. Every molecule's been turned over. Yeah, you must remodel constantly. Make sense? So, osteopetrosis is a hereditary defect where there's a problem with the osteoclast function. So I can't break the bone down to remodel it. So the bone gets thicker and thicker and thicker and thicker and thicker. So all over the body, you will see thick sclerotic bones. On X-ray, it's the only disease where you see symmetrical generalized osteosclerosis. Every bone. Some diseases give you 1 or 2 bones big and thick, but this gives you all the bones thick, all the bones dense. So that's a very characteristic finding. Now, in fact, the bones get so thick they get deformed. So do you remember a bone is supposed to go like this, supposed to come down? There's a diaphysis, then the metaphysis where it gets wider, and then at the end of the bone you have the epiphysis, right? What happens here is these bones get really thick and dense, especially in the metaphyseal region. So it starts looking like one of those test tubes in the lab. Do you remember those Erlenmeyer flasks? That's what it looks like. And again, this bone is really dense compared to normal. It's really dense. So dense. And it's thick. It's wide at the metaphysis. So they call that the Erlenmeyer flask deformity. All right, now I got good news for you. We can actually cure the transplant, bone marrow transplant. Why? Because where do osteoclasts come from? Let's see. They come from monocytes. Where do monocytes come from? Monocytes come from the bone marrow. If I get you a new marrow, the new marrow will make new monocytes that work great. They'll fuse with their friends and become multinucleated giant cells. Those are called osteoclasts, and they'll break the bone down for you. Make sense? Bone marrow transplantation is curative, and they're going to ask this because they want to see, do students know where osteoclasts come from? Well, they're just giant macrophages all stuck together. Where do macrophages come from? Monocytes. Where do monocytes come from? Marrow. So that's a nice question to see if students understand that bone marrow will cure these patients. They'll get you get somebody else's marrow who actually can break your bone down for you. Now, we got a couple forms. Which one's going to be the bad one? The recessive or the dominant? Oh, yeah, recessive. We call it the malignant type because it presents very young and very severely. They get dense bones, but they fracture like crazy and they die very early because of anemia, infection, and hemorrhage. Now, tell me why. Why are they dying of anemia, infection, and hemorrhage? Because as the bone gets thicker, what happens to the cavity, the marrow cavity? Yeah, they crush their marrow. They squeeze it. It's called a myelophysitic process. You push the bone marrow out. There's no place for it to go. So if you take a look down here, what's going to happen is the bone marrow, it's called a myelophysitic process, where you replace all the hematopoietic tissue. It gets replaced by bone and fibrosis. It just crushes the cavity. So yeah, you get narrowing and fibrosis of the cavity, the medullary cavities. So that's going to lead to pancytopenias. Now, where will the bone marrow go? Oh yeah, the bone marrow will go to your spleen and your liver. That's called extramedullary hematopoiesis. So your spleen and your liver try to make the blood for you. Not going to do such a good job. We see tearing red blood cells. You can, because there is some myelofibrosis, so you may see some teardrop cells, and you're also going to see very immature cells. You'll see leukoerythroblastosis because the spleen and liver are not good at making blood. So you're going to see a lot of immature cells as well. Okay, all right, because it's getting all pushed out. So these patients are going to die of pancytopenia. That's what they're dying of here. Now, in the dominant form, that presents a lot later. That presents as adults, and they call it the benign form. It's not as severe. It presents as adults who often get lots of fractures. They can get mild anemia, but they don't typically die. But this is important: cranial nerve impingement. Do you remember in med school where you had to look at the base of the skull and you had to identify all the foramen and which nerve and which artery went through each one? And I hated that so much. Do you remember that? Oh, I hated that. Well, all the cranial nerves go through foramen. They go through foramen. So as the bones get thicker and thicker, what happens? It crushes the nerves. So they get cranial nerve palsy. They can get blindness, deafness, facial palsy is very common. So look at here, cranial nerve compression, because the foramen gets narrowed. So they get blindness, deafness, facial nerve palsies, all because of the narrowing of the foramen. Remember that? Yeah, we had to memorize all those. I hated that. It's the exercise in uselessness, but they like to do it. Now, another type that you should know about is this one for biochemistry: carbonic anhydrase type 2 deficiency. Carbonic anhydrase type 2 deficiency. If you're missing this enzyme, you're going to get the same disease, and the reason is the osteoclasts break the bone down by making acid. Where do they get the hydrogen from? The carbonic anhydrase enzyme. If they don't have carbonic anhydrase, they can't make the hydrogen to make the acid. They can't break the bone down. So you got osteoclasts that can't make hydrogen. They can't break the bone down. So that's why you get osteoporosis. Now, in addition, you can't hydrogen and bicarb is not going to be exchanged in the kidney, so you're going to get renal tubular acidosis. Makes sense. Makes sense. Carbonic anhydrase is needed by the renal tubule cells to exchange bicarb and hydrogen, and it's also needed by the osteoclasts to make hydrogen to break down the bones. Make sense? Interesting stuff. So that's a pretty interesting deficiency. Carbonic anhydrase deficiency, you're going to get osteopetrosis plus acidosis plus some calcifications in the brain. They're not sure why, but they get cerebral calcifications as well. Carbonic anhydrase type 2 deficiency. All right, now did I miss anything for pathology? Oh, yes. These bones are dense and thick, but they're still brittle. They still fracture because it's like chalk. It's very dense, but if you don't remodel it, it's still going to, like chalk, it just breaks because it's not constantly remodeled. That's the problem. Again, treatment is bone marrow transplant. Bone marrow, get them new bone marrow, get new monocytes. All right, now 5 stars. First 5-star thing in this chapter is Paget's disease. Paget's disease. Another name for it is osteitis deformans. because your bones do get thick and you get deformities, especially in the skull. They get these big foreheads like a lion. They get these lion-like foreheads. And they thought it was due to inflammation. They thought it was inflammatory, so they called it osteitis. So osteitis deformans. Now let's read it together. It's a localized disease of bone remodeling. Oh no. So that means you're going to get thick bones, but they're still going to fracture because you're not remodeling in that area. You're going to get first excessive bone resorption. Why? Because we think paramyxovirus is infecting the osteoclasts and turning them on. Turning them on. Yep. So we think that paramyxovirus is infecting the osteoclast. We actually see inclusions in this disease in the osteoclast. So we think that there's a virus like paramyxovirus infecting the osteoclast. Then it turns them on. So they break it down, break it down, break it down. They just get activated, break down the bone. Then the osteoblasts say, what are you doing? You're breaking down the bone. I got to build this back up. So the osteoblasts get turned on, but they're all upset. They're all upset because somebody broke the bone down. I got to fix the house. So they lay down the bone really quickly, and it's disorganized. So even though this bone gets thick, it's weak because it was laid down in a disorganized fashion. Okay? I kind of think of it like this. Who is the osteoblast? It's the woman. She makes things. Women are nurturing. They make things. Who's the osteoclast? The man. They break things. Right? Man smash. Man smash. Right? So woman is the osteoblast. Man is the osteoclast. He breaks things. Right? Now, the man gets infected by someone else. Right? He's supposed to pay attention to his woman. He gets infected by somebody else. And then he breaks the house down. He just gets infected and breaks the house down. And the woman's like, what are you breaking our home? I'm so upset with you. I'm going to have to fix this now. Well, if I have to fix it, I'm going to be upset the whole time. And so she fixes it, but she's so upset with him, she lays it down really disorganized. So the house gets fixed, but it's going to be damaged. It's not perfectly made because she was so upset by him. Remember, ladies, the only one who can upset you the most is your man. He's the one who can accept you the most. Yep, he's the one who pisses you off the most. Think about it. Who pisses you off the most? It's your man. Absolutely. So you're so upset, you lay it down, you lay it down. Now, of course, what's going to happen? The man poops out. So he's breaking down the bone. He said, he poops out and goes lay down. And the woman keeps going. She keeps fixing and fixing. So the bone gets really, really thick over time because the osteoclast poops out. The woman keeps doing the work, and she makes the house thick again, but it's still going to fracture. That's the problem. All right, now we think it's probably due to one of these slow virus infections with paramyxovirus. There may be some genetics here as well, susceptibilities. But here's what we know. Over age 40 is when it typically occurs, and usually of European ancestry. So do you remember Beethoven? Do you remember Beethoven? Oh, yes. Remember he went deaf after age 40? Deaf after age 40? Yeah, because as these bones get thicker, you get palsies. So we think he had it. He was older than 40. He went deaf. We think he had it. Remember he had a big head? He had like a big head with crazy hair. So yeah, they typically get a big hair. They get these deformities. So we think either he had Patch disease or he had neurosyphilis because he liked prostitutes. So I'm a romantic. I like to think that it's Paget's disease, but there is some speculation it might have been neurosyphilis as well. Might have been. Might have. Don't know. I'm a romantic. I'm going to pretend it's Paget's because he did have a big head. He did have a really big head. Now, for forms of this disease, monostotic, meaning one bone, is not very common. It's usually polyostotic, a couple of bones involved. Which bones? Well, it's usually the skull, the pelvis, and the femur. Those are the most common sites. Skull, pelvis, and femur. Now, for Paget's, there's 3 stages. As I told you, first the man gets infected by somebody else, and he breaks down the house. He breaks it. So osteoclast activity predominates. The bone get really thin. Then the woman says, what are you doing? I'm going to fix this. So he's still breaking it down, but she's now fixing it. So now alk phos is going to go up because she's active. So alkaline phosphate is going to go up. And then finally, the man poops out, and the osteoblast, the woman keeps working, right? You keep working while the man's on the couch, right? And sure enough, the bones get thicker and thicker, but they still fracture. That's called the burnout stage, when they get really thick and they just fracture. Now, let's go to number 4. Under the microscope, the key here is haphazard arrangement of the cement lines because she lays the bone down, but it's disorganized. Remember, lamellar bones should have cement lines like this. They should all be lined up because all the collagen should be in the same direction, right? What you're going to see here is a mosaic pattern. So it looks like this way and this way and that way. Looks like you put a bunch of stones together. That's what a mosaic is. Put a bunch of fit a bunch of stones together. That's what the cement lines are doing. They're going this way, that way, the other way. I mean, it looks haphazard. It's supposed to be lamellar, layered. Look at this thing. So even though this bone is getting thick, the collagen is all disorganized. It's going to fracture so easily. So this involved bones are going to get thick, but they're very weak and they fracture. Now, since the skull is usually involved, the hat doesn't fit. So always remember, if the hat don't fit, think Paget and acromegaly. If the hat don't fit, think Paget and acromegaly. Those are the two where the hat don't fit. So the hat won't fit, but the rings and the feet are still okay. The rings and the shoes are fine. So it's just the head that's getting big. And since the skull is involved, you get cranial nerve palsies, particularly deafness. That's why Beethoven is thought to have gone deaf. Now, if your skull gets really big, you get a big forehead. Big forehead. They call it a lion-like forehead. So they call it lion-like facies. It's a big, big forehead. So if you look at pictures of Beethoven, they often show him with a big forehead. So maybe he's got it. Okay. All right, now let's go to clinical features. Most cases are asymptomatic. Asymptomatic. So a lot of people, you find it at autopsy. But if there is symptoms, it's often bone pain and deformity. You get these deformities and fractures. Now, if you feel the bone, it's really warm because in the marrow, there's a lot of vascular proliferation because the bone's getting thicker, it needs more blood. So there's a lot of vascular proliferation. Unfortunately, that vascular proliferation often creates shunts. AV shunting. So what happens is you're pumping blood in the artery and it comes right back in the vein without going through capillaries. So that's going to lead, look right here, the AV shunting within the marrow leads to high output cardiac failure. High output cardiac failure. That is very classic. High output cardiac failure and very easy to test, by the way. So heart failure can lead to heart failure. Here, bring that picture in. Let me see that picture. Let me see Beethoven. What does he look like? He got a big head. Look at that. Look at that forehead. You see that forehead? That thing is pretty big. I don't know. See the size of his forehead? I mean, it does look kind of like a lion. That's pretty big. Beethoven may have. And he has the crazy hair on top of this big head. He looks like a lion with a mane. Holy heck. So I don't know. Maybe. Or maybe he's looking at a prostitute. I'm not sure. So hard to tell. Aren't you glad we're not royals? All right, now we got to talk about what did I miss here? Let's see. Got the warm bone. They got the AV fistulas. Oh, very important. X-ray. Some of the bones are going to be large and dense, and others are going to be very lytic. So you're going to see both. You're going to see lytic areas and sclerotic areas. Lytic and sclerotic, depending on which stage it's in. Now, very important for the labs. Alk Phos is sky high because the osteoblasts are on. Okay, so number one, osteoblasts are on. I could do a bone scan. It'll light up on a bone scan. And number two, osteoblasts on. You'll see alk phos like crazy. Now, when the bone gets broken down, it gets released in the urine, and you'll see hydroxyproline. Not just proline, hydroxyproline means it was part of collagen, right? It was hydroxylated. Then it got broken down. That's the breakdown product. Okay, now one last thing they could ask. The high output cardiac failure is a major complication, but another complication is the bone is growing. If the bone is growing, you can get cancers. You can get cancers here. So that's very important. So they can get osteogenic sarcomas. We call them secondary because they're secondary to the Pagets. Okay? You guys feeling good? Oh my gosh, another hour. Whew, time flies. So far, so good. So we'll take a break. We'll come back. We'll do osteoporosis. So far, so good. All right, see you guys in a little bit. Okay, we're finishing up our quest there. We're getting close to the end. It's been quite a journey with you guys through all of pathology. It's been so much fun. And we're getting down to the last few chapters here. So it's kind of bittersweet. It's nice to be finished with the book almost, but at the same time, I'm going to miss you guys. So you guys got to keep in touch with me. You got my email, right? Keep in touch with me, my email, okay? I also have the website for you, but unfortunately, I have to take it down right now. So the website will be back in a little bit. I got to make a couple of changes to it, and then the website will be back for you guys. All right, now let's finish up with osteoporosis versus osteomalacia. Very confusing between the two. They can trick you. Osteomalacia and osteoporosis. Now, osteo means bone. Porous means holy, right? Like sieve, water goes through it. So very porous bones, very holy. Look at all the holes. That's some holy bone, all right? Look at the holes. So these vertebrae are very fragile and they're easy to fracture. Now, by definition, we're going to call this decreased bone mass or osteopenia. So normal bone, just not enough of it. Normal bone, just not enough mass. That's the problem. So these bones are thin and fragile and they fracture very easily. It is the most common bone disease in the United States, and most commonly it's going to be in postmenopausal because of the estrogen, and Caucasian because genetically they have lower bone density, and females. So females, postmenopausal, Caucasian, very classic. Now, elderly also will get it as well because as you get older, your osteoblasts kind of poop out. They kind of poop out as you get older. So you got the estrogen dependent one, and you got the elderly one where the osteoblasts basically slow down. All right, now let's talk about pathogenesis. Primary causes are the estrogen deficiency cases. So postmenopausal women, don't forget Turner's. Turner's going to get accelerated osteoporosis. We've got genetic factors. African Americans have stronger bones. They have higher bone density than Caucasians. Lack of exercise. Older age, the osteoblasts kind of slow down as you get older. Nutritional, you need calcium and vitamin D, right? Now, secondary causes are secondary to things like immobilization, like studying for USMLE, you're immobilized in a seat. Endocrine problems like Cushing's. Thyrotoxicosis. Whenever you have too high a thyroid hormone, it does hypermetabolism state. You do break your bones down a little bit more than you make them. Malnutrition, calcium, vitamin D, vitamin C, these are all important for making strong bones. Steroid use, that's a very important secondary cause. And then diseases like Gaucher's, where we had lytic bone lesions, and osteogenesis imperfecta. All right, now let's go to clinical features. These patients are going to have thin bones, so bone pain and fracture are basically what we're looking for here. And it's usually the weight-bearing bones that are most at risk. So they get fractures of the vertebrae, those are called compression fractures. They'll get fractures of the hip fractures. It's a big problem. And older people get hip fractures, they go in the hospital, they spend time there, they will come out dead. So unfortunately, that's a big problem. The hip fractures, a lot of morbidity and mortality. When they fall on an outstretched hand, they fracture the radius, the distal radius and or ulna. That is called a Colles fracture. What else? They lose height because of all the vertebral fractures, and they get kyphosis. They bend forward. On X-ray, you will see generalized radiolucency, so osteopenia all over the place. Now, we want to check density. How do you check density? Well, right now we got the DEXA scan. We're working on CT and MRI ways as well, but right now DEXA, it's going to help measure the density. Now, question, what is the definition of osteoporosis? Density, that's what? There you go. Less than 2 or 2.5. Yeah, 2 or 2.5 standard deviations. There you go. Very good. So it's going to be compared to somebody at the same age as you. You're at least 2 standard deviations away from the mean. All right, laboratory studies. What is calcium? Normal. What's phosphate? Normal. What's alphos? Normal. All the labs are normal. All the labs are normal. That's the key. All the labs are normal here. All right, anything else? Treatment. Now, estrogen replacement therapy is controversial, so that will not be something that you should be picking. Controversial. You have to do it on a patient-by-patient basis. But something that's definitely recommended is weight-bearing exercise taking calcium and vitamin D. No controversy there. Weight bearing, that does not mean swimming. Swimming is great for joints because no weight bearing. But weight bearing, lifting weights, running, anything where you struggle against gravity. And of course, calcium and vitamin D, everyone should be taking supplements. Now, if you need more help, bisphosphonates, the dronate drugs, they all end with dronate. Bisphosphonates, very effective here. And of course, calcitonin. Calcitonin can be used as well because it puts calcium in the bone. I always remember calcibonin puts calcium in the bone, calcibonin. All right, so these are all possible therapies that could be done. Now, let's compare it to osteomalacia and rickets. Now, osteomalacia is the one that you're going to confuse it with. Rickets, they're going to have all the deformities. It's going to be pretty obvious. But osteomalacia can be quite confusing with it. So let's take a look here and talk about osteomalacia and rickets. Both are caused by decreased mineralization of the newly formed bone. So you make the osteoid, but it doesn't get mineralized, doesn't get calcified. This condition is usually caused by a deficiency or abnormal metabolism of vitamin D. Now, why would that happen? Well, maybe you don't like dairy. You don't have any dairy in your life. Maybe you have malabsorption of fat malabsorption, vitamin D. What if you live in Canada? You don't see the sun too much during the winter. Actually, more like Alaska. You don't see the sun half the year. Renal and liver disease because they activate vitamin D. So these are all going to be risk factors for vitamin D and therefore calcium deficiency. Now, for children, they get deformities. We're going to call this rickets. So they tend to get bone that is basically malformed. They form it, but it's malformed because it's under middle-ized. Now, we're going to look for certain deformities, especially things like skull deformities, where they're laying in the bed, so they get flat in the back and they get round in the front. We call this cranial tabes and frontal bossing. Cranial tabes and frontal bossing. As they get older and they start sitting upright, now they're going to get the rachitic rosary and the curvature. They get the backwards curvature, the lordosis, when they start weight bearing like that. So rachitic rosary is the costochondral junction, and they wind up getting the lumbar lordosis. Now, when they start standing, now their legs start curving and they get bowing of the extremities. This is all due to the weight bearing on soft bones. Weight bearing on soft bones, things are going to curve, right? Yeah, you always have to have calcium. If you don't have calcium in your diet, you'll start breaking your bones down faster. Now, the earlier you make sure you have good calcium, the better, right? So if you're eating a good diet with lots of fruits and vegetables, you're probably getting good calcium. But of course, in America, we don't eat good diets. So the earlier you start your supplementation, the better off you are. Because basically after 30, for bone density, it's all downhill. So we got to make sure that the downhill slope is not steep. If you get any deficiencies, it becomes very steep. You get osteoporosis quickly. Make sense? So you want to do it. Starting around 30 is the best time to start taking supplements. Okay, make sense? Weight bearing exercise. Oh yes, you want to get the maximum bone density you can. So in your 20s, you should be doing weight bearing. 20s to get the maximum bone density, because after 30, it's all downhill. So try to get up as high, the peak as high as you can, and then try to delay it from going down as quick as you can. Okay. All right, now let's compare this to osteomalacia, because it could be kind of confusing. Osteoporosis versus osteomalacia. Osteo means bone, malacia means soft bones. Now, this is, again, due to a problem with mineralization of the osteoids. You make the bone, but it doesn't get calcified. So now you get thin, fragile bones that are going to fracture. So bone pain and fracture, just like osteoporosis. What else? It's usually the vertebrae, the hips, and the wrists, just like osteoporosis. The x-ray shows lucency, osteopenia, just like osteoporosis. So what I'm trying to say here is it looks very similar to osteoporosis. So a key is the lab. In the lab, obviously calcium is low. It's a vitamin D problem. Calcium is low, phosphorus is low, and of course alk phos is high because the osteoblasts are making the bone. It doesn't get calcified. They got to make it again. It gets broken down. They got to make it again. It doesn't get calcified. So osteoblasts are going crazy here. So notice the labs for osteoporosis are normal. The labs for osteomalacia are very abnormal. So very important we see the difference there. That's one of the key distinguishing feature. All right, now how about this one? Osteomyelitis, inflammation of the marrow, osteomyelitis. Now, often it's pyogenic. It's usually bacterial, pyogenic. All right, the most common cause of the infection is going to be a hematogenous spread. So it's coming hematogenously into the bone. So therefore, it usually occurs in the metaphysis where a lot of the blood vessels enter. So metaphyseal region, most common site here. It can also be directly coming from an adjacent area. So like I've seen diabetics, they get these non-healing ulcers, and it ulcerates all the way down to the bone. So when the bone now gets exposed, it can now get an osteomyelitis because it's direct extension of the infection. Okay? But most cases are going to be hematogenous. Now for bugs, the rule is for bones and joints, staph, 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 staph. Bone infection, joint infection, staph, 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 staph. Other bugs can do it too. E. coli, strep, Haemophilus. Now salmonella, you always have to think about sickle cell because that's a very rare infection. Salmonella osteomyelitis, think sickle cell. Pseudomonas is more common in IV drug abusers and so forth. Oh, don't forget sex active, gonococcus. Sex active, gonococcus. Sex active, gonococcus. Otherwise, go staph, 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 and you're all good. Now, when you have osteomyelitis, you're going to have fever. You can have some white count elevation. And in the area of the infection, you'll have pain, redness, and swelling. Now, if you do an x-ray initially, it may be normal. But after a while, you'll see elevation of the periosteum and eventually a lytic lesion. Lytic lesion with a sclerotic rim. Sclerotic rim is the new bone coming in. So lytic lesion with a sclerotic rim, that's the classic description. Now this lytic area, if you looked under the microscope, it's basically dead bone. They call it the sequestrum. Dead bone and pus in the middle. Then around it is the involucrum. Involucrum is a $10 word for new bones coming in to heal this. So that's what you see at the edge, sclerosis. So lytic lesion, that's the sequestrum, the dead necrotic bone. Around it's the involucrum, that's the new bone growing in to try to heal. So remember these terms, sequestrum and involucrum. These are classic terms to give you for a patient who's got osteomyelitis. Now, for diagnosis, we may have to do we'll do blood cultures, but we may have to do a bone biopsy and bone cultures ultimately to find out what it really is. So treatment, antibiotics, and you may need drainage as well. Now, complications. If you're lysing bone, you're going to get fractures. No doubt about that because of these abscesses that are forming. Now, since it's always inflamed, inflammation, you're at risk for amyloidosis. And these abscesses want to drain, so you can get draining sinus tracts. Now, a very interesting case is they had a farmer with osteomyelitis for many years. He had no time to go into town. He started draining pus out the skin. So he just squirted perfume and wrapped it up. Well, after a year of the pus coming out of his skin, he noticed a mass there. Yeah, it's going to be squamous cell from all the irritation, from all the pus coming out of that sinus. So yeah, you get squamous cells at the site of draining sinuses when they're draining for years. And then notice this, since the bone is being irritated and it's growing and then lysing and growing, you can get bone tumors. This is going to be a secondary osteogenic sarcoma, secondary to the inflammation. All right, now one of the non-routine bacterial infections is tuberculosis. That's an atypical bug, right? TB loves to go to bone. About 1% of all TB infections, it will go there. Loves bone. Now, when it goes there, you'll get pain and tenderness, fever, night sweats, weight loss, all the stuff we know. On a biopsy, you'll see caseating granulomas with destruction of the bone. Now, it usually involves the vertebrae. So we call that Pott's disease. And then very important to remember, along the vertebrae are your psoas muscles. So getting a cold psoas abscess is very common because it's right there. Psoas abscesses, psoas signs, psoas irritation, very common because right there. All right, now for miscellaneous bone disorders, there's only one that's really important. It's this one, avascular necrosis of the femoral head. Okay. Oh yeah. Anything bone related, ortho guys get excited about. They get excited. Orthodox get boners all the time. All right, now for avascular necrosis, A means without blood supply, causing necrosis. So avascular necrosis basically means you're infarcting your bone. So it's basically aseptic necrosis. Another name for it's osteonecrosis. Now to see it, MRI is a really good technique. MRI is really good at picking up dead bone. So MRI is here. Now, this is caused by several things. Some of the most common is going to be trauma to the hip and steroid use. These are the two biggies: steroids and trauma. Steroids and trauma. So all these bodybuilders, they wind up blowing up their hip. They wind up blowing up their hip from this constant steroid use. Now, another one they'll ask on USMLE is sickle cell. Sickle cell anemia. Sickle cells get stuck in the hip long term, you get infarction. Gaucher's, we talked about involving bone a lot. And then don't forget diving. If you're a diver, long term, you're at risk for Caisson's disease, which is chronic nitrogen gas emboli. All right, now obviously it's not good to infarct your bone because the articulating surface, if you infarct the bone inside, the articulating surface will cavitate down, and now you get arthritis. You're going to need a hip replacement. That's the problem. It gives you a lot of arthritis because it destroys the surface. Like when you destroy the bone, the surface caves in, and the articulating surface is all messed up. All right, now let's get to tumors. Tumors are very important. Now, the malignant ones are the most important, but we'll do them all. We'll do them all. First one is an osteoma. Bone, benign bone tumor. So it's a benign tumor that usually involves the skull and facial bones, especially like the mandible and the maxilla. Now, what they like to ask about this is its association with Gardner's. Remember, that was an autosomal dominant polyposis syndrome. So they're at risk for colon cancer. They also get fibrosis of the abdomen, fibromatosis of the abdomen, and they also get epithelial inclusion cysts. So those are the classic three lesions, right? So osteomas of the jaw, fibromatosis of the abdomen, and inclusion cysts. That's Gardner's syndrome, right? Sickle cells get stuck in the joint. That's avascular necrosis. Sickle cells get stuck in the joint, you infarct your bone. All right, now let's talk about the next one. Osteoid osteoma. John, that sounds painful. Osteoid osteoma. It is painful. That's the key. This is a benign but tender or painful. It's usually in the tibia of a teenager. So, very simple. Tender, teen, tibia. Tender, teen, tibia. Tibia that's very tender in a teenager. And what's kind of interesting is that pain tends to be worse at night when everything is quiet, but if they take some aspirin, it feels better. Feels better. So it hurts at night or early in the morning when things are quiet, and they take an aspirin, it will feel better. Now, eventually, it's going to keep bothering them, and they're going to get an x-ray. What does it look like? A central lucency with a sclerotic rim. Now, that sounds exactly like something we just did. What does that sound like? Central lucency with a sclerotic rim. Sounds like osteomyelitis. Sounds very similar. Sounds very similar. So often what we'll do is we'll go in and we'll curate it out, and we'll see it's not pus. It's not an abscess. No, it's not an osteomyelitis. It's basically a bone-producing tumor. It's making osteoid. So it's all this osteoid that you'll get out. The central nidus is osteoid. It's in the center, and it's surrounded by this sclerotic rim of bone. So you just curate it out, and basically you're cured. But the key is it's painful. Small, painful tumor in a teen's tibia. Now, what if you have the same tumor, but it's larger, and it's in the vertebrae? Well, then we call it an osteoblastoma. So it's basically the same thing as an osteoid osteoma, except it's larger, and it's usually in the vertebrae. So that's what's different about it. It's larger, it's in the vertebrae, but it's the same exact kind of tumor. All right, now here's the most common tumor that is in the bone that's benign. It's called an osteo, means bone. Chondroma means cartilage. Now the name for it is an exostosis. Exostosis. Yeah, this is a benign outgrowth of the metaphysis where the growth plate is. So basically, here's what's happening. Here's the end of the bone. Here's where it gets narrower. Okay, right here is your epiphyseal growth plate. That's the growth plate. So what basically is happening, it's a bony outgrowth that on the surface has a cap of cartilage. This cartilage is the growth plate cartilage. So it's an outgrowth of the epiphyseal growth plate. So it's going to occur at the end of the bone. And the key description is it's a bony outgrowth with a cap of cartilage, right? Osteo means bone, cap of cartilage on top of it. Okay? So let's repeat. It's a metaphyseal growth capped by a cartilage cap. And it comes right from the epiphyseal growth plate. It's probably more of a malformation than a real tumor. Okay, now it occurs in adolescence, and it's usually at the ends of the long bone. Now, there are genetic forms where you have a whole bunch of them. That's called an osteochondromatosis, if you have a whole bunch of them. So they're hereditary forms where you have a whole bunch of them. And unfortunately, when you do have that, they have the risk of turning malignant on you. So they can be malignant transformation rarely. All right, now let's go to this one. They call it a benign lesion, but it can spread. Isn't that weird? They call it benign, but it can spread. So the books call it benign. We'll call it benign too. It is called the giant cell tumor of bone. The giant cell in the bone is your osteoclast. So a better name for this is an osteoclastoma, a giant cell tumor of the bone. Now again, it's not that common. It's benign, and it's made of multinucleated giant cells with stromal cells. Now, the neoplastic cell is the stromal cell. Yep, these are really osteoblast precursors. That's the neoplastic cell. So wait a second. Why are there giant cells? Because they're reacting. Remember, osteoblasts turn on osteoclasts. So if you have an osteoblast precursor, it's going to express a lot of rank ligand. Remember, rank ligand turns on the rank receptor of the osteoclasts. So that's why the osteoclasts are the benign. The osteoclasts are normal cells. They're just reacting to these osteoblasts because these osteoblasts are flashing they're flashing their rank ligand at them, so they get all turned on. And you see a bunch of osteoclasts there. Isn't that weird? That's weird, huh? So they call it a giant cell tumor, but the giant cells are not the tumor cells. They call it an osteoclastoma. The osteoclasts are not the tumor cells. They're just reacting to the osteoblast precursors that are really the neoplastic cell. Now, this is more common in females, and it's slower growing, so it tends to present a little bit later than most bone tumors. So 20s, 30s, 40s presents later. Most bone tumors are in teenage, so this is a little bit later. It's a little slower growing. Now, clinically, this is a bulky mass with pain and fractures. That's how all bone tumors present. Mass with fractures. On X-ray, very important point here. Very important point. You're going to see a lytic lesion because osteoclasts break down the bone, except at the edges. So the bone is basically left at the edges. So you'll see edge of bone, edge of bone, edge of bone, edge of bone. So they say it looks like a soap bubble. Bubble, 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 bubble. It looks like a soap bubble lesion. Soap bubble. Okay? Yeah, the osteoblasts are the ladies. So they're flashing the rank ligand at the guys, and the guys are breaking down the bone. Yeah, they're flashing their rank ligand. And that turns the guys on, and they break the bone down. So the guys are just, but they're reacting. They're doing what guys do. Right? They're not really causing any trouble here. All right, now, good news is this is benign. So what we do is we can go in there and curette it. If it comes back, we curette it again. Or you could try to do an en bloc resection. But the key is this is benign, so we can usually get it out. Now, the bad news is it does like to recur and about 4% metastasize. So I've always had an issue with this. Yeah, my attending says, John, it is a benign tumor, giant cell tumor bone. And I'm like, well, if I tell the patient, you have a benign tumor, and then it's the 4% that metastasized to his lungs, and I'm going to say, you have a benign tumor, but it spread to your lungs. I think they're going to be kind of pissed because it spread. Benign tumor is not supposed to do that. So they call it a benign tumor, but if you ask me, I think it's a malignant tumor that just acts in a benign fashion most of the time. Because if it can spread, isn't that malignant? Isn't that the definition? So again, I am in the minority. Everyone calls it benign. If you ask me if it spreads, that's malignant, but we will call it benign. Benign tumor that can spread. Okay. All right, now let's look at the pathology here. It's the only one that's a red-brown mass because bone is white. All the other tumors are white tan. They're bone. This one breaks the bone down. Osteoclasts break it down. So this is a red-brown mass, not a white mass. It usually occurs at the end of the bone, the epiphysis. That's what occurs. And it's usually around the knee. A lot of the tumors occur there. Knee, very common site. So it's the end of the bone, usually the femur or the tibia, right by the knee. Under the microscope, you'll see lots of osteoclast-like giant cells with the background of mononuclear stromal cells. Those are the ones who are really the neoplastic cell. Okay, so look at the X-ray. They love that soap bubble. Bloop, 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 bloop. Soap bubble. Bloop, 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 bloop. Soap bubble. They love it. They love the location. Knee, usually by the epiphysis, the end of the bone. All right, now let's go to the most important of all. They're going to ask two bone tumors like crazy, Ewing's and osteosarcomas. Those are the two most tested by far. Now, another name for an osteosarcoma is an osteogenic sarcoma because it's making bone. So this is a tumor of osteoblasts. This is osteoblasts making bone. Okay, that's what they call it, osteogenic. Now, it's the most common primary malignant tumor of the bone if we exclude myeloma. Myeloma is a tumor of the marrow, but the marrow is part of the bone. So technically, myeloma is technically the most common bone tumor, but it's not really of the bone, it's of the marrow. But technically, myeloma is most common. This will be the most common primary if you exclude myeloma. Now let's talk about who gets it. It's usually males, but teens. That's when most malignant tumors occur. Teenage, because that's when the bone is growing, the growth spurt. That's when you get tumors most of the time. Now notice this, RB is knocked out and P53 is knocked out. Yep, so let's repeat. Osteosarcomas have RB knockout and P53. So could this occur in familial retinoblastoma? Yes. Could it occur in Lee-Fermini syndrome? Yes. So this can be associated with Lee-Fermini and it could be associated with familial retinoblastoma. Yeah, 2 hits are required. 2 hits are required. So we have 2 hits on RB, 2 hits on P53. Both genes are knocked out, and therefore people with familial retinoblastoma, people with Lee-Fermini, are going to have a higher risk of this as well. Now let's go to clinical. All bone tumors present as localized pain, swelling, and potentially fracture. Now you're going to get an X-ray. The key lesions here are the Codman's triangle. Codman's triangle and the sunburst. Okay, now Codman's triangle. Okay, these tumors occur in the metaphysis, where it gets narrower. That's where they occur, metaphysis. Now what happens is, as the tumor goes through the cortex here, it lifts the periosteum off of it. See, the periosteum is lifted off of the cortex. That's Codman's angle, because it lifts it off. Now, in addition, as it goes through the bone, it's going to create bone, which will be calcified in these layers. So as it goes through, it gets calcified and calcified. That looks like rays of a sun. So again, here's this the line. You see these lines of calcified bone that it's making. So it looks like a sunburst. Sunburst. So I'm just blowing this area up. Looks like a sunburst. So sunburst because making bone that calcifies. And it's got Codman's angle because it lifts the periosteum. All right, now treatment. You got to be aggressive here. This is a malignant tumor. So we're going to do surgery and chemotherapy. And by the way, we're going to try to spare your limb, which I do limb sparing surgery, but if I have to, I'll amputate because this is a very aggressive tumor. Because prognosis is poor, got to do something. So we got to get it out, and it spreads hematogenously to the lungs. So if there's a single met, I will cut that out too. Yep, so you might lose your limb, and you might lose a lobe of lung in an attempt to save you because it's a teenager, they got the whole lives ahead of them. And this is a malignant tumor. So we try to be aggressive here to try to save their lives. That's the goal, save their lives. All right, now secondary occur in older people because it's secondary to something else. So this occurs in older people who have a history of either Paget's or radiation to bone, that's a risk factor, or osteomyelitis. These are secondary to the inflammation, secondary to radiation, secondary to Paget's. Okay, they're equally evil. You don't want any of these, right? Sarcomas typically spread hematogenously. That's a rule for all sarcomas. Leiomyosarcoma, rhabdomyosarcoma. Sarcomas, for some reason, love to invade vessels. So that's a pretty good rule to keep in mind. Sarcomas, they usually spread hematogenously. Yeah, it's very interesting. Not sure why. Now let's go to pathology. These osteosarcomas are usually in the metaphysis. As I drew it here, where the bone gets wider, that's usually where they occur. And again, usually around the knee. Knee is a common site for malignant tumors. Usually occurs near the femur or the tibia. It produces a firm white tan mass because it's bone. It's osteogenic bone. Okay. You'll see a lot of necrosis and hemorrhage. Under the microscope, you'll see anaplastic osteoblasts producing osteoid in bone. So it's a tumor basically of osteoblasts. They're very ugly looking, they're highly malignant, but they still make bone. That's why they call it osteogenic sarcoma. Okay, good with this one? There's a lot here. They like the RB question, they like the P53, they like retinoblastoma association, they like the Codman's angle, they like the sunburst, they like the fact that you have to be aggressive. In older people, they're going to ask you the risk factors like Paget's, radiation, and osteomyelitis. Okay. Yeah, and I got an email. John, they had a patient with a bone tumor. They said the tumor was making osteoid, and they said it looked ugly. Well, dude, what do you think that means? If it's making osteoid and it's ugly, that's an osteogenic sarcoma. If it's making osteoid and it's benign, then it's an osteoma or osteoid osteoma, if it looks benign. So if it's making osteoid, it's osteogenic, right? Because he memorizes the book, he doesn't think of what things mean. If an ugly tumor is making osteoid, that's an osteogenic tumor. It's going to be malignant, osteogenic sarcoma. If it's benign and it's making bone, you call it osteoma or osteoid osteoma. Cool. All right, now the other big one is Ewing's. But before I get there, I just want to mention this one. This one kind of violates all the rules we've done so far. It's not around the knee. It's not in teenagers. It kind of violates all the rules because it's cartilage. It's a malignant tumor of cartilage. It's a chondrosarcoma. So this is a malignant tumor of chondroblasts, and it can arise by itself, or it could be secondary to an enchondroma or exostosis or Paget's disease, which is basically turned into tumor. Now, males get it more than females, but they tend to be much older. 30s, 40s, 50s, so much older. Kind of like a giant cell. Giant cells are older. These are older as well. It's not teenagers. All right, where does it present? Well, it's the same thing. Mass with pain and swelling. They all present that way. But what you're going to see here are atypical chondrocytes and chondroblasts. It's cartilage. It often looks very glistening and kind of shiny and glistening like cartilage normally does. Very shiny and glistening. And it's most common in the pelvis and shoulder. So everything's around the knee except for this one, pelvis and shoulder. All right, now let's get to Ewing's. Ewing's and osteogenic are the two biggies. Now this is a malignant tumor and it's kind of undifferentiated. So we're going to see small round blue cells, small round undifferentiated blue cells within the marrow cavity. Now males get a little bit more than females, but it's usually teenagers and younger. Teenagers and younger. It's got the youngest average age. So 5, 6, 7-year-old, think Ewing. It's got the young teenagers and younger. Now the classic translocation is 1122. Ewing's 1122. Now if you remember the basketball player Patrick Ewing, his jersey number was 33. So 11 plus 22 is Patrick Ewing's jersey number 33. Make sense? I don't know about you, but maybe you don't know him. So tell me what you know about basketball players. They're really, really short, right? No, they're really, really tall. Look, they have long legs. They got long legs. See that? They got long legs. And then they shoot. They shoot the basket, right? You shoot the basket like this. You shoot the basket like this. Don't you shoot the basket like that? You shoot like that. You throw the ball. You shoot like this. Shoot it up, right? So 1122. Now he's going to fly through the air trying to shoot it, right? Flying. So Ewing's flies through the air. Ewing's flies through the air. See him flying like Jordan? Ewing flying through the air. Those are the fusion genes from this translocation. All right, now all these bone tumors present with pain and swelling and tenderness, and if you bump it, you get a fracture. Now for x-ray, we're looking for onion skinning. Onion skinning. Because as it goes through the bone, it's usually in the diaphysis, the long portion, starts here. When it goes through the bone, it makes layers of periosteal new bone. So that's what they mean by onion skinning. It makes layers of periosteal new bone. Now, treatment. We've got to be aggressive here. We're going to give chemo. We're going to do surgery. We're going to do radiation. We're going to try to save you because these have got the youngest average age. Now, as I mentioned, it's the diaphysis of long bones. Again, usually around the knee. Femur, tibia, very common sites. It's going to be a white tan mass like most bone tumors. It's going to have hemorrhage and necrosis because it's malignant. But here's the key. Under the microscope, they're undifferentiated cells. So they're small, round, blue cells. They look like lymphocytes, but lymphocytes don't line up. It's trying to be neural, so it lines up. Cells line up. Small, round cells line up around a space. And what they do is they throw their cytoplasm in there, kind of being like nerves, trying to make little projections like nerves. See this? Throwing the cytoplasm in there. So that's why they call this a pseudorosette, because it's not empty. If it's empty in the middle, you call it a true rosette. If there's something in the middle, you call it a pseudorosette. These are called Homer-Wright pseudorosettes. So that's another one of those buzzwords you're going to need to know. So small round blue cells with Homer-Wright pseudorosettes. Now it's not unique for this. It happens in other immature tumors as well. Like, do you remember retinoblastoma? Do you remember medulloblastoma? They also have the same Homer-Wright pseudorosettes as well. Yep. So it's just small round blue cells means undifferentiated. When they make the Homer-Wright, they're trying to be like nerves. It's like evidence of neural differentiation. All right, so again, very high yield. Got the onion skinning, got the diaphysis around the knee, you got these Homer-Wright pseudosettes, you got the cool translocation, the cool genes. Shouldn't miss. Okay, good. All right, last is metastasis. Lots of tumors love to go to bones. So you got prostate loves to go, and that's the one that tends to be osteoblastic. Most other ones are lytic. What else? Breast, lung, thyroid, kidney. So lots of tumors go to bone, but they're almost all lytic. If they say blastic, think prostate. Think prostate. What else has Homer-Wright pseudosettes? Lots of things. Medulloblastoma, neuroblastoma, retinoblastoma, a lot of the blastomas. Cool. So medulloblastoma, retinoblastoma, neuroblastoma, a lot of the blastomas have it. Okay. Homer-Wright pseudosettes. It's evidence of neural differentiation. Neural differentiation. Cool. All right. 2 chapters remain. So let's take a break here. We'll come back. We'll do some joints. It's the end of the day. We'll do some joints and then some skeletal muscle. All right. I'll see you in a little bit. Okay, gang, here we go. Chapter 28, 29. It's the end of the marathon. We're almost there. We can see the end at the light at the end of the tunnel. We're gonna make it. We're gonna make it. Now let's do some joints. Good news. You know osteoarthritis, you know rheumatoid, and they're gonna ask it. I love it when they ask stuff we know. I love that. Now let's just compare them, make sure we got all the details here. Osteoarthritis, also known as degenerative joint disease, that's another name for it. This is going to be wear and tear of your joints. Now, specifically, it's the cartilage that gets worn out. So there's a problem with the cushion. The cartilage gets worn out. Now I got bone grinding against bone with no cushion. That's degenerative arthritis. Now, which joints are going to wear out first? It's the weight-bearing ones. Those are the ones that are doing the most work. So the knees, the hips, and the spine are most common sites. It tends to be asymmetrical. One knee will burn out before the other one does. And it's non-inflammatory. It's not caused by inflammation. Now, rheumatoid is an inflammatory disease. This is an autoimmune, systemic autoimmune disease. So this is going to affect not the joints, but things outside the joints as well. So we'll see in the blood rheumatoid factor and anti-CCP antibodies. We'll see rheumatoid nodules on the extensor tendons. Now, for the joint pathology, it's all about the synovium. This is a synovitis. You have inflammation and proliferation of the synovium. Now, which joints are involved this time? It's the small joints. So the hands, the feet, the wrists, the ankles, it's the smaller joints. And it tends to be symmetrical. Both sides are usually involved, and it can move. One day it's the wrist, next day it's the MCP. It can move around. Okay, but clearly it's inflammatory. No doubt about that. Now let's talk a little bit more. We got the big picture here. This is cartilage. This is synovium. This is big. This is small. This is non-inflammatory. This is inflammatory. Let's talk more about this degenerative arthritis. Now, as we know, we're all going to wear out our joints as we get older, right? We use it, we wear them out slowly over time. So this is loss of the articular cartilage without inflammation. Now, it's the most common type of arthritis, and the risk increases with age. So at least one joint in 80% of people are going to be involved when you get over 70. So not us, we're perfect, but 80% of other people over 70 are going to have one joint involved. So clinically, and especially if you're a laborer, right, we're laboring with our minds, right? Now clinically, it's a slow onset of joint stiffness. Yeah, stiff joints. There's this deep, aching joint pain. But here's the key. It gets worse the more you use it. The more you use it, because you got bone grinding against bone with no cushion. So the more you use it, the worse it's going to be. Joint stiffness, that's worse the more you use it. Now they're going to get this creaking sensation. It's called crepitus. That's the bone grinding against the bone. And they tend to have effusions and joint swelling as well. Now at the edges of the bone tries to grow. You get these bony outgrowths. They call them osteophytes or bone spurs. Osteophytes or bone spurs. And if these get big enough, they can compress nearby nerves and cause problems that way. Now, on X-ray, we would expect to see narrowing of the joint space because the cartilage is missing. So now I got bone against bone. There's no like joint space anymore. It's all hitting each other. So loss of the joint space. You'll see sclerosis because when bone hits bone, it gets thicker to protect itself. And you'll also see bony cysts and osteophytes as well. These are all the classic findings we're going to look for. Now, for the pathogenesis, this is biomechanical factors, so aging, wear and tear. But there's also some biochemical factors here. These chondrocytes, once they get injured, they start messing everything up. And they don't stop behaving once they get injured. Now, risk factors, clearly obesity. Yeah, it's a lot of weight bearing all the time. Joint injury. If you're a football player, a lot of football players, when they retire, they get a lot of degenerative arthritis because of all the injury. Ochronosis, remember black cartilage? Alkaptonuria, black cartilage. Diabetes, because they lose position sense. They get shortcut joints, right? So they lose position sense, they twist their joints, they damage their joints. People who have had trauma. And of course, hemophiliacs. If you're going to be an orthopedic surgeon, you need to know hemophilia because all the hemophiliacs bleed in the joint and eventually require joint replacement. Hemophilia and joint replacement, very common. All right, now let's go to number 4, the pathology. We're looking for weight-bearing joints here, so knees, hips, and spine. It tends to be asymmetrical. One side wears out before the other one does. And the key lesion really is the loss of the articulating cartilage. Now, when bone grinds against bone, it polishes it. Polishes it. That gets a fancy name. They call it eburnation. Polishing of the surface of the bone because the bone is grinding against bone. Now, this is also going to create the bone, it's going to stimulate the bone to get thicker. So in those areas, to get very thick subchondral bone. It's basically sclerotic because no cushion. So it stimulates itself to get really thick to protect itself. Now, you can also see a lot of bone cysts. You can see loose bodies, not that kind. Now, this is a joint mouse. It's a piece of cartilage that breaks off and floats around in the joint. Just floats around, and it can kind of get wedged in the joint sometimes and cause a locked joint. The joint can get stuck with the cartilage. Little piece gets in there. What else? We talked about the osteophytes, which are the new bone growth at the edges. Those are called bone spurs. And they get fancy names when they occur in the hands. You call them haberdins and bouchards. It's a $10 word for osteophytes in the fingers. So let's take a look here. Now always remember like this. When you're going this way, you're going from your body distally. B comes first, right? B comes first. So bouchards, haberdins. Bouchards, haberdins. B and then H. So as you're going this way, bouchards is going to be here. Haberdins is going to be here. So this one right here, that's a nice haberdins node right there. Haberdins. Let's see, this one looks like more like a bouchard. This big one here, this is a bouchard here. Haberdins and bouchards. Just $10 words for osteophytes in the fingers. That's all. All right, now rheumatoid is a big one. They love to show this picture, and you're like, rheumatoid, it's rheumatoid, it's rheumatoid. But they're going to ask second steps. They're going to ask second steps. Oops, what am I supposed to repeat? I'm sorry, I didn't see what you're writing. I got to make this bigger again. They reset it and everything got smaller. I got to get a bigger computer. Okay. Yeah, I know. It's just fancy names. Oh, I just remember haberdins and bouchards. Bouchards comes first. Osteophytes here. If you have osteophytes here, you call it haberdins. So B and then H. B and then H. B and then H. So depending on location, you just give it a different name. It's still an osteophyte, but it's different location. They called it a different thing. Okay, whatever. It's cool with me. So bouchards, haberdins, bouchards, haberdins, bouchards. If they have it there, haberdins if they have it there. Okay. All right. Now they love to show this picture, but they're going to ask a second step. Everyone knows what rheumatoid arthritis looks like. At least we should. So they're going to show the picture or an X-ray like that, and you're going to have to say, okay, a second step. So let's see what they are. Okay, systemic chronic inflammatory disease. You get arthritis. Ooh, you make antibodies. That's testable. Ask about the antibodies. And you get things outside the joint too. That's important. You get stuff outside the joint. Now, females are going to get it 4 times more than males because it's autoimmune. And the incidence is usually in the reproductive age, 20s, 30s, 40s, 50s. That's you're going to see it. Now, for HLAs, DR4 seems to be a bigger risk factor. So DR4. We think it's autoimmune reaction, maybe triggered by infection. If you have the right genetics, we're not sure. We're not sure. We know it's immune, and we know you have HLA associations. All right, now clinical features. It's usually the smaller joints, the hands, the wrists, the knees, the ankles. It tends to be the smaller joints. It tends to be symmetrical. So both sides are going to be affected pretty much equally, and it can move. But here's the key. Morning stiffness, that gets better when you move it. Remember, degenerative arthritis, the more you use it, the more it hurt because bone was grinding against bone. Here, it kind of loosens up after a while. So after like half an hour to an hour, they start feeling better and better and better. So this one actually gets better the more they use it. What do you see in the fingers that are involved, or the hands are involved? You're going to see swelling, redness, and warmth. And it's very common to involve the MCP and the PIP. MCP would be the most common. So these joints are going to be all swollen, MCP and PIP. Now on X-ray, very characteristically, you'll see osteoporosis next to the joint. Remember, degenerative had thick bone sclerosis. This has osteoporosis next to the joint, and sometimes erosions as well. Now, you'll see an effusion, but they both have an effusion. Doesn't really tell the two apart. Now, for pathology, 3 things you must know here. Number 1, it's a synovitis. So we have a proliferation of the synovium because all inflamed. When it proliferates, it covers over the joint. It just basically proliferates and covers the joint. That's like a cloth. They call it a panis, cloth. Covers the joint. So that's number 2. pannus formation. So synovitis grows, covers the joint. Then what does it do? Well, this inflamed tissue becomes a scar and it fuses the joint. That's called ankylosis. Ankylosis. First it's fibrotic, then it becomes calcified and becomes bony. So 3 classic things you need to know. Number 1, it's a synovitis. Number 2, it proliferates over the joint. We call it a pannus. And then number 3, this pannus will now become fibrotic and calcified, and the joint will be lost. It'll be fused. It won't work anymore. Okay, make sense? And that's also going to, this fibrosis contracts and it makes the joints deform. It pulls it in one direction, pulls in the other direction, and you get these joint deviations, these deformities. Now always remember, wrist goes radial. So wrist radial. MCP goes ulnar. Wrist radial, MCP ulnar. Wrist radial, MCP ulnar. Okay, because MCP is the most commonly involved joint. So wrist gets radial deviation of the wrist, and then you get ulnar deviation at the MCP joint. So we come back here and take a look at this picture. I think you can see it. You can't see the wrist. I wish you could see the wrist, but you could see the MCP is getting ulnar deviated. See the fingers going this way? See, it's ulnar deviation. Ulnar deviation. Then if you can see the wrist will be going like this. The wrist is going radially. So wrist is radial, and then the MCP is going ulnar. MCP is the most common site. MCP and PIP, 2 most common. All right, now they tend to get also swan neck deformities and boutonniere's deformities. Whoa, cool. Again, it just depends on which joints are involved which way. So swan neck deformity is hyperextension of the PIP, flexion of the DIP, where boutonniere is flexion of PIP and extension of DIP. Again, fancy words, very nice. Basically, they're getting deformities. They're getting deformities here and here. See this? Here and here, here and here, here and here. So those would get fancy names, swan neck and boutonniere. So classic deformities. All right, now they're probably not going to ask that. They're going to give you that. They're going to ask you what's wrong in the knee. Well, in the back of the knee, in the popliteal fossa, you're going to get Baker's cyst. These are synovial cysts. They're very common in bakers because they're always bending down to put stuff in the oven, and they're very common in rheumatoid arthritis. Baker's cysts, very common. Now, for the laboratory, the SED rate is up because you got inflammation. No doubt about that. They tend to have high levels of immunoglobulins, but we're going to look for rheumatoid factor. That's pretty good. Now, if they ask you, what is rheumatoid factor? You'll say it's an IgM. What's its target? FC of IgG. So it's an IgM, but it's against IgG. That's its target. And you'll see it in a lot of patients. But what's a better antibody? Rheumatoid's okay, but what's better? Anti-CCP. You bet. Anti-CCP. That's better. So look for anti-CCP. That's a much better antibody to look for. So we can look for them both. We can look for rheumatoid factor, which is an IgM, and we can look for IgGs that are the anti-CCP antibodies. Okay? Yeah, this occurs, we think, this citrullination, or because of smoking. So a lot of these patients are smokers. That might be the trigger here. That might be the trigger. When they smoke, they get citrullination of the proteins. That creates a new antigen that these people with DR4 may recognize. Me and you, we don't recognize it, but DR4, they may recognize it. So that may be playing a big role here. Smoking may be a big a contributing factor to the development of this disease, because smoking causes citrullination of your peptides. All right, let's talk about anything else. Yeah, let's talk about extra. They want second steps. Diagnosis, too easy. They want to know about the Baker's cyst. They want to know about the citrulated proteins. They want to know about the rheumatoid, or they want to know the extra articular. So they can get things like low-grade fever, malaise because of inflammation. They can get lymphadenopathy and weakness. Oh, but they can get a vasculitis. They can get a necrotizing vasculitis because of the immune complexes. That's interesting, vasculitis. This is interesting too. Rheumatoid nodules. About 25% get rheumatoid nodules, usually on the extensor tendons, usually around the elbow most commonly. So on the forearms and elbows, you'll see the extensor surfaces will have these nodules. Now, it's a central area of fibrinous necrosis, and then it's surrounded by these epithelioid macrophages. It's just like basically almost a granuloma, almost, but it's just eating up this dead tissue. Now let's talk about syndromes. Do you remember Sjogren's syndrome? That's high yield. That's high yield. That's high yield. Maze, you have to, when you ask about hypersensitivities, you have to tell me which part is type 3. Which part are you talking about? Are you talking about the vasculitis? That's type 3. Are you talking about the cerebral necrosis? That's type 3. If you're talking about synovitis, that's type 4. That's rheumatoid, type 4. Okay, makes sense? So it really depends because most autoimmune diseases have more than one hypersensitivity. It's more than one, more than one. So make sure you ask, you're clear about what you're talking about because the vasculitis is type 3, the fibrinal necrosis is type 3, but the actual rheumatoid arthritis synovitis is type 4. I'm glad you asked that because that would be a nice question. It's very confusing. But when you get to immunology, immunology is very confusing because most immune diseases, we thought there were one. No, they're more than one. So it always depends on which part they're asking about. Now, for Sjogren's syndrome, we talked about the association, right? We said Sjogren's syndrome gets about 60% of them will get rheumatoid. Well, here about 15% of rheumatoid will get Sjogren's. So they like each other. You get one, you get the other. How about this one? Felty. Felty, wait. I think I felt something. I think I felt a spleen. Exactly. They get these big spleens. That's Felty syndrome. I felt a spleen. Yeah, and their spleen gets big and eats their neutrophils. So they get neutropenia. So let's repeat. If you have rheumatoid and you get a big spleen with neutropenia, we call that Felty syndrome. Clearly, what do you think they're going to come in with if their neutrophils are low? What do you think they're going to come in with? Yeah, I think they're going to come with infections. That's a pretty good idea. So rheumatoid arthritis gets recurrent infections. They see the neutrophils counts low. Feel for a spleen. Feel for a big spleen. And we're not sure why it happens. And why does the spleen decide to sequester it? We don't know. Now, we did talk about Kaplan syndrome with a C, right? That was any pneumoconiosis who develops rheumatoid. That's a nice association. Pneumoconiosis with rheumatoid. What else? Amyloid, because this is inflammation. It's the most common cause of secondary reactive amyloid. Most common cause because it's a chronic inflammatory disease. So look at all the things they can ask. The amyloid, Kaplan's, the Felty syndrome, the Sjogren syndrome. They can ask about the antibodies. This is why they really like rheumatoid. Very easy to test. All right, now we got to compare rheumatoid to the seronegative spondyloarthropathies. We got 4 seronegative diseases. Now let's see, what do they have in common? Well, they're all B27 positive. All B27. Number 2, they're all asymmetrical. Remember, rheumatoid was symmetrical. These are all asymmetrical. Asymmetrical. Number 3, so B27, asymmetrical. I better write this because you can't read anything I'm writing here. B27 positive. They're all asymmetrical. They all are seronegative. That means no rheumatoid factor. No rheumatoid factor. So here's the key. They're an arthritis, so you're going to think maybe it's rheumatoid, right? So here's the difference. They're B27 positive, not DR4. They're asymmetrical. Rheumatoid is symmetrical. And they're rheumatoid factor negative. They don't have rheumatoid or CCP. Those are found in rheumatoid. So again, we always have to differentiate these from rheumatoid. Now there's 4 of them. The first one is called ankylosing, which means fusion, right? Ankylosing spondylitis, fusion of the spine. Now this is going to be common in young men who are B27 positive. And it's going to involve the spine and the sacroiliac joints. Now when the spine fuses, you kind of have like this bamboo appearance. They call this a bamboo spine. Bamboo spine. It's all fused. Bamboo spine. And then the sacroiliac joint, I can't even see it. Where's it? Where it's all fused? Where's the sacroiliac joint? It should be right here somewhere. It's all fused. So they get asymmetrical fusion of the sacroiliac joint, and they get fusion of the lumbar spine. Now tell me, if your spine is fused, what are you going to complain of? That's right. You're going to have back pain and stiffness. This young kid can't bend. He's got back pain, he can't bend. I mean, if I said it's a 70-year-old says, I got back pain, I can't bend, you're like, yeah, you're old. But is it 27-year-old? I can't bend over? Oh, yeah. That sounds like a med student. You're right. You're right. So, very important to realize this is too young to be having back problems. Something's going on here. So, you get an X-ray, you'll see they're fused. You'll see that this fusion of the joint here, this is very characteristic of this disease. Now, it can be triggered by something like inflammatory bowel disease. I think if you remember from our chart, our chart about Crohn's and ulcerative colitis, they had ankylosing spondylitis as one of the extra bowel problems they can have, right? It's interesting, right? Cool. Yes, very good. Yes, they can't bend. Exactly. Put them to the wall, they can't bend over. Yeah, Big Bang Theory. I didn't know what Big Bang Theory was until like 2 years ago. Somebody said you have to check it out. I started watching it and I couldn't believe it. It was so cool. I had to watch the whole thing. I'm such a big geek. I think they kind of jumped the shark now. It's not quite as interesting as it used to be. But wow, it was a great show. Great show. Very interesting stuff. All right, so that's a very important ankylosing spondylitis. Very, very testable. Now I got a couple more here. Now riders, we can't call it riders. Why? Why can't we call it riders? Because we found out the dude worked for the Nazis. If you're a doctor, you can't work for Nazis. That's no good. So now we call it reactive. Reactive arthritis instead of riders. Oh, I left out an A. Let me try that again. Reactive. That's better. Reactive. We call it a reactive arthritis. Reactive arthritis. Riders is a reactive. Now, again, who's going to get it? It's people with B27 positivity. It's males more than females, and they're young and sexually active. Young, sexually active. Young, sexually active. Now, you're going to see a classic triad. You can't see, you can't pee, you can't climb a tree. Now, honestly, they can see. They just have red eyes. They got conjunctivitis. They can pee, it just hurts. It hurts to pee. It's very painful. And they can't climb a tree. That's true. They can't climb a tree because they have an arthritis of their ankles and knees. Unless you're an American ninja, it's very hard to climb a tree with just your upper body. Usually you like your ankles and knees to help out, right? So that part's true. So the saying is can't see, can't pee, can't climb a tree. Pretty good mnemonic, but they actually can see. They can pee, it just hurts. Can't climb a tree, that's true. Now, this is, I said sex active because it's often triggered by an STD. Which one? Which one? Which STD? So close. You're so close. You're so close. Chlamydia. 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 It's often triggered by chlamydia. Now, if it's not chlamydia, it'll be one of those bloody diarrheas, a bacillary dysentery like Shigella, Yersinia. One of those bloody diarrheas can trigger it as well if they have B27 positivity. All right, that's why I said young, sexually active. That's why they have a urethritis, right? Urethritis, very characteristic. All right, now let's talk about this. Enteropathic arthritis, too easy. Why? Because you're going to have an inflammatory bowel disease and B27 positive. Well, if you got a bowel disease and then you got arthritis, I think we'll call it an enteropathic arthritis. Too easy. How about psoriatic arthritis? Again, too easy. You got psoriasis and you're B27 positive? I think you got a psoriatic arthritis. But there are two important things they could ask about this. Psoriasis, what does it start with? Let's start with P and an S. The S stands for sausage digits. Their fingers swell up in psoriatic arthritis, and they get these sausages, like their fingers become sausages. So S stands for sausages. P stands for pencil in a cup deformity. So on X-ray, it literally looks like the end of the bone is eroded, so it looks like a pencil sitting in a cup. So pencil sitting in a cup. So here's this will be the cup, end of the bone, and then this bone kind of gets sharpened like a pencil. So it looks like a pencil sitting in a cup, deformity on X-ray. So those are kind of cool things for psoriatic arthritis, a pencil in a cup deformity on X-ray, and sausage digits. So sausage digits, you X-ray them, you see a pencil in a cup. Okay, so psoriasis. That's kind of cool. I'd ask that. But again, if you got psoriasis and you get arthritis, it's probably a psoriatic arthritis. B27 is going to be positive. Good. Those are the seronegative spondyloarthropathies. Now let's go to crystals. We got gout versus pseudogout. Gout versus pseudogout. Podagra, the big toe, the painful big toe. Now this is going to involve, remember, rheumatoid was MCP? This is going to be the metatarsal phalangeal, MTP joint, right? So not MCP, MTP. That's going to be the most commonly involved of your big toe. It's called gout. Now, this is due to high uric acid, but that's not good enough. Having high uric acid is not good enough to get it. You got to have high uric acid, and it has to deposit in the joints. Because I know a lot of people have high uric acid, and they don't have gout. It has to actually decide to deposit for whatever reason. When it deposits, we call it monosodium urate crystals. And do you remember what they look like? They look like needles. They look like needles, but they're negatively birefringent. So my rule is negative needles, negative needles, negatively birefringent needles. That's gout. Negative needles. It's all about the crystals. That joint is inflamed. It might be septic. You got to put a needle in there. You suck out the crystals. You'll say, oh, it's negative needles. It is gout. All right, now this is going to give you episodes of acute inflammation because these crystals are chemotactic for neutrophils. Neutrophils come in and it's very painful. Now, how does the uric acid get high? It could be overproduction or it could be under excretion. Now, primary gout, that's the most common type, primary gout is idiopathic. Idiopathic. Who gets it? It's the disease of kings. It's males when they're old and eating red stuff. Red meat, red wine. It could be any kind of alcohol. But red meat, red wine. That was the disease of the kings. Bring me my red wheat, my red wine, and my red women. That's the king. They could eat whatever they want. So they ate their red meat and red wine, and they would get these painful big toes. Podagra. Make sense? Now there's also secondary gout cases. Secondary. This is often seen with breakdown. So when you have acute leukemias or Burkitt's lymphoma, remember the tumor lysis syndrome? Tumor lysis syndrome will give you gout and renal failure. Another one is renal disease because you can't excrete it. And don't forget Leishmania, the biochemistry. Oh, Dr. Turco is smiling right now, I guarantee it. Leishmania. Now, it's X-linked, so it's going to be males. It's a deficiency of a really long enzyme, so we have to abbreviate it, HPRT. Now, this enzyme is important for the salvage and reuse of purines. If I can't reuse the purines, I can't salvage them. They all have to get broken down to uric acid because I'm missing the salvage enzyme. I can't recycle. If I can't recycle, everything goes to the trash bin. So then you're going to make so much uric acid that your brain is going to get intellectual delays. You're going to get intellectual delays. You're going to get spasticity. You're going to get self-mutilating behaviors. Now, what is that? What is self-mutilating? Does that mean going to med school? Is that a self-mutilating behavior? Yeah, pretty much, right? Yeah, they bite their lips until they bleed. They eat their fingertips off, down to the bone. Not just the fingernails, the fingertips. They literally, until they're gnawing on bone. Classic. So they bite their lips, they bite their fingertips off, and they bang their heads. They're headbangers. They bang their heads against the concrete wall because of the neurologic abnormalities, because of the uric acid in the brain. For some reason, it makes them decide to hurt themselves. Very, very weird. So all this uric acid in the brain gives it mental delays, intellectual disability is the preferred term, spasticity, and self-mutilating behaviors. And of course, they get gout too, but that's like the least of their worries, right? When you're eating your fingertips off and bang your head against the wall, having a painful big toe is least of your worries. Yeah, I know I bang my head against the wall sometimes too, but I'm usually listening to music. Now, clinically it affects the big toe. We call that podagra, and it's a painful, big, inflamed toe. But it could also affect the ankle, the heel, the wrist, the ears. It could be anywhere. Now, the key is you got to do the aspiration, and you look for those negatively birefringent needles. Negative needles, negative needles, negative needles, negative needles. And of course, there'll be lots of neutrophils around too. That's why that's so painful. Now, if you look at it grossly, it looks chalky white. That's what the gout crystals look like. Gross, they're chalky white. They get so big, they destroy joints. So they can ulcerate the skin, these collections, and destroy the bone and joint. Very destructive, these gouty deposits. Complications are going to be joint destruction and deformity. You can get stones in your kidney from uric acid, and that can lead to renal failure. Now, treatment. For acute inflammation, NSAIDs are what we do first. If the NSAIDs fail, you go for colchicine. Now, for chronic gout, we got to stop the production or help the excretion. So usually we try to stop the production by giving allopurinol. Now, if the kidney is not excreting it, you can give probenecid, which will help the kidney excrete it. So for excretion, probenecid. To prevent more production, allopurinol. So for acute, stop the inflammation. For chronic, to get the uric acid down, allopurinol, and then help the kidney if the kidney needs help. Make sense? So acute versus chronic. Now let's talk about pseudogout, better known as chondrocalcinosis, calcification of your cartilage. So on X-ray, gout was lytic. This has calcifications in the cartilage. That's a big clue. So if you do an X-ray of the joint, this painful joint, you'll see calcifications in the cartilage. And this is chondrocalcinosis. You're depositing calcium pyrophosphate, so I can see it on X-ray. Now, again, it's going to lead to inflammation because it's chemotactic for neutrophils. Again, these patients are usually older, so it's just like gout. Most common site here is the knee. Now, again, you got to suck out the crystals. When you do, they're positively birefringent, polygonal. So polygons like rhomboids and rectangles. So I just remember positive polygons, pseudogout. Pseudogout is positive polygons. Pseudogout is positive polygons like rhomboids and rectangles, polygonal shapes. Make sense? Gout, negative needles. Gout, negative needles. Pseudogout, positive polygons. Now, I'm making a big deal here because it's the crystal that tells you what it is. So what's the Burke going to do? Let's see. Gout is the big toe. Pseudogout is the knee. What are they going to do? They're going to switch them on you. They're going to say, an old guy comes in with a painful big toe. Oh, it hurts, it's swollen, podagra, right? Then they're going to say they suck out positive polygons. Pseudogout. Pseudogout. If I say there's a painful earlobe, I suck negative needles out of the earlobe, it's gout of the earlobe. So the crystals will give us the diagnosis. Location doesn't matter. It's the aspiration that matters. That tells you what it is. Okay, feel good? Yeah, they always like to do that. They like to give you weird locations, like in the earlobe. Doesn't matter. Negative needles, gout. Positive polygon, pseudogout. It's that simple. Okay, now what about arthritis? For infectious arthritis, it's very similar for infections of the bone. Very common. You know, Parvinda, that's a good question. I've done this for many years. I don't hear them asking that. I don't hear them asking that stuff because it really doesn't matter. It doesn't really teach anything. But I can teach it to you. Let me teach it to you. It's kind of fun. Yeah. Okay. Let's do it. Negative needles, positive polygons. What does negative and positive mean? Okay, we're going to polarize the light. So we're going to polarize it, put it through a slit. So all the light is going in one direction. So we're going to polarize it. All the light is going in this direction. Up and down, up and down. All the light's going up and down, up and down. It's going through that slit. So that's polarization. Now, if you line the crystals up with it, if you line the crystals up with the long axis here, if it is yellow, when it's parallel, that is called negatively birefringent. On the other hand, if you line up the crystal and it's blue when it's lined up, that's positively birefringent. So what does negative and positive mean? It means what color it is when it lines up with the polarizer. So if it lines up and it's yellow, that's negative. That's what gout's going to be. If it lines up and it's blue, that's positively birefringent. Now, question, what if the crystal, you have one crystal, what if this crystal's like this, though? Well, for gout, again, let me draw a line here. For gout, if it's lined up, it's yellow. If it's not lined up, it'll be blue. But what matters is the one that's the color is when it's lined up. I don't care about the one that's not lined up. I care when it's lined up. If it's lined up, it's yellow. It's negative. Now, what about this one? It's lined up, it's blue. What if it's not lined up? Oh, it's not lined up. It'll be the other color. It'll be yellow. But I don't care about that color. I care about what color is it when it's lined up. And by convention, if it's yellow, it's negative. If it's blue, it's positive. That's it. Again, do you care? that going to change your life? No. But that's how we do it under the microscope. That's actually what we actually do. We line it up. What color is it? And that tells us positive or negative. Okay, but it's easy to remember. Easy to remember. Okay. All right. All right. Now, infectious arthritis is the same as infections of the bone. It's very similar. So how did the infection get in the bone? Hematogenous. How does it get in the joint? Hematogenous. Now, it can also come from direct extension of nearby infected areas, like infected bones can go into the joint, infected soft tissues can go into the joint, same way. Okay, what's the bug going to be? Well, it's going to be staph, 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 staph. If they're sexually active or they're missing complement, you go for gonococcus. Make sense? Otherwise, staph, 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 staph. Sexually active, and if you're missing complement, MAC, remember the MAC attack, then you pick gonococcus. Gonococcus, you need the MAC for it. All right, clinically, what happens when your joint is infected? It's going to be tender and painful and swollen and red. So here's the rule. Any inflamed joint must be tapped, because if you miss an infectious one, you'll destroy the joint. You'll destroy the joint. Any red, swollen, inflamed joint must be tapped, because I don't want to miss an infected joint. You'll scar it. You'll lose the joint forever. So very important when you see a tender, red, painful joint. Could be gout, but you got to put a needle in. Make sure it's not septic. Very important. Now, large joints are most commonly involved, like the knee, the hip, and the shoulder. When there's infections, it's often see that with gonococcus too. Big joints. All right, joint aspiration should be done, and the fluid is going to be cloudy. It's going to be cloudy because it's full of pus. It's going to clot right away because it's full of pus. It's going to have lots of neutrophils because it's full of pus. Now, you can do a gram staining culture to try to see an organism, but don't wait to treat. You treat it empirically. Always cover staph, right? If there's actually have to cover gonococcus. Cover it based on what you think it could be, and then when the cultures come back, you can change it. But don't wait. Gram stain can help you a little bit too. Gram positive diplococci, gram negative diplococci, gram negative diplococci. I'm thinking gonococcus. Okay, so gram stain can help guide us if it's positive. If it's negative, you treat it empirically. Don't wait. All right, now what about Lyme's? This is always a fun one. Lyme's disease. Yeah, this is due to the spirochete Borrelia burgdorferi. It's like a dork. Borrelia burgdorferi. It's like a dork. It's like you're bitten by a dorky spirochete. Now, this is an arthropod-borne disease. It's spread by deer ticks, Ixodes, the Ixodes species. Now, this is going to give you a skin rash where you get bit. So right where you get bit, it's like, woo, woo, that's where the dork bit you. That's where the dork got into you. Borrelia got into you right there. You got bitten by the deer tick. Borrelia the dork, Borrelia burgdorferi got in there. It's like a bullseye. Doesn't look like a target. Looks like, I don't know why, but I feel like I want to shop. Do you feel like you want to go shopping? I don't know why. This rash reminds me of some shopping thing. I don't know. It's like Target or something. I don't know. Target rash, right? It's like Target. You should advertise Lyme's for Target. All right, now in addition, it's going to go to other places like your joints. Getting a migratory arthritis is very characteristic. An arthritis that moves around. Now the interesting thing is, under the microscope, it looks a lot like a synovitis. It looks a lot like rheumatoid arthritis, but they don't get the joint deformities. Now they also get obviously brain involvement, so meningitis. Ooh, don't forget the cranial nerve palsies. Bilateral Bell's palsy. Bilateral Bell's palsy. Think Lyme's disease. Very common. And for the heart, they often get heart block. Heart block, very common at heart block. So heart block, Bell's palsy, meningitis, migratory arthritis, and look for this beautiful rash. This is getting more and more common nowadays because we have a lot of deers. A lot of deers running around. Less forest from the running. So we're seeing a lot more Lyme's disease. Who just got diagnosed with it? What was it? It was Avril Lavigne was diagnosed with it. Who else? There was some other big famous person diagnosed recently. I can't remember. Avril Lavigne and somebody else. Somebody else who was like, I don't know, I was exhausted all the time. I couldn't get out of bed. I don't know what was wrong with me. And they finally figured out it was Lyme's disease. Yeah, we don't think about it very often, but it's getting more and more common. Okay, skeletal muscle pathology and joint. Skeletal muscle pathology here. Okay, do you remember normal? You have two types of skeletal muscle. You got type 1, which is slow twitch, and type 2, which is fast twitch. Now, for type 1, that's our slow twitch. It's great for posture. So to hold this posture, look, I'm making a number 1. My body's making a number 1. To stand at attention like a number 1, you need your postural, your type 1. So basically, it's like this. Standing, a guy standing at attention, that's type 1. So make a type 1, make a number 1, and put a head on it. A guy standing at attention. Those are your slow twitch. So they don't poop out. Slow twitch, postural, sustained tension. Now, what are they going to use for energy? Well, aerobic. They need a lot of energy to stand all day like that. So they're going to burn fatty acids in the Krebs cycle. Fatty acids in the Krebs cycle make lots of ATP. Now, to do Krebs, we need a lot of mitochondria. Mitochondria has iron in it. So on gross, what color are the fibers? Because of all that iron, they're red. They're red. So when you have turkey or dinner, dinner with turkey or chicken, and you ask for the red meat, the dark meat, you're asking for type 1 slow twitch. Yeah, type 1 slow twitch fibers. That's what you're looking for. Type 1 slow twitch fibers. Make sense? Yeah, it makes sense. Yeah, so tell me, why is red meat so delicious? White meat is not the red meat. Oh, red hamburgers, yeah, red meat. Why is it so delicious? Because it's fatty. It's fatty. Tastes good. Fatty. Yum, 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 yum. But notice that's not good for us. So they always say, red meat, come on, take it easy on the red meat. A lot of fat in there, a lot of fat, but it tastes good. But it's a lot of fat in there. Perfect correlation with dinner. So next time you ask for the dark meat, the red meat, tastes good. It's fatty. It's fatty. Not as good as light, lean white meat. Now, type 2, I never forget it, fast twitch. Imagine a boxer. 2 arms, right? 2 arms. Fast, 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 fast. Fast twitch, fast twitch, fast. Boxer's got 2 arms. That's type 2. Type 2's got 2 arms hitting the bag. 2 arms hitting the bag. Let's put 2 arms there. 2 arms hitting the bag. There's your type 2. A boxer hitting the bag real fast. So this is fast twitch. A boxer going fast. 2 arms. 2. Fast, fast, fast. So this is for quick, purposeful bursts of energy. And this is going to need energy quick. I can't wait for the Krebs cycle. It takes too long. So how do I get energy fast? I got to go anaerobic glycolysis. Anaerobic glycolysis, I'll break glycogen down, get energy right away. Now, problem with that is lactic acid. So it's quick to fatigue. You can't go all day because lactic acid builds up. Now, do you need mitochondria for anaerobic glycolysis? No. So very few mitochondria. That's why this is white meat. It's white because there's not much iron in there. It's not much iron. So this is the white meat. When you eat the lean white meat, not quite as tasty as the red meat. Still good, but not quite as tasty as the red meat. And it's healthier for you because it's not fatty. It's glycogen. It's not fatty. Perfect correlation of pathology in dinner. So tonight, when you get with your lady, you say, honey, can you pass me the type 2 fast twitch fibers, please? She'll be like, what? I'm sorry, the type 2. No, I need iron. Can you give me the dark meat? Because it's got more iron in it. That's why it's dark. Did you know that? The red meat is dark because it's got more iron. It's got more mitochondria in it. Yeah. You knew that, right? Yeah, of course. I'm a doctor. Soy doctor. Okay, right? Right? Turkey, chicken, it works great. You'll impress everyone at dinner time. They'll think you're insane, but you'll impress everyone. All right. Now, let's talk about inflammatory myopathies. Inflammation of muscle. So tell me, you think you're going to get weak? Oh, yeah. You think the muscle's going to release some of its muscle markers? Like, let's see, what would a muscle release? Maybe myoglobin? Yeah. Maybe some AST? Yeah. What else? Maybe some aldolase? Yeah. Aldolase? Yeah. But remember CPK? CPK. CPK. So all these muscle markers are going to go up. Yes, CKMM primarily, you bet. So all these muscle markers are going to go up when you have inflammation of your muscle. They're all going to have that. Make sense? Because the muscles being inflamed, they're breaking down. So this is very important. If you're weak and your markers are up, you better do a muscle biopsy. Muscles breaking down. It's not normal for muscle to break down. So let's repeat. These patients come in and they're weak. You find elevations in CPK, aldolase, AST, myoglobin. The muscle's breaking down. You say, what's going on here? I better do a biopsy here because these muscles are weak and they're breaking down. This is not good. Now, is this muscle weak? Is it going to be tender or non-tender atrophy? If it's inflamed, tender or non-tender? These muscles are going to be tender or non? Yeah, they're probably a little tender. So if you palpate them, might be a little tender because they're inflamed. So there's going to be some tender atrophy with increase in these muscle markers. Now there's three of them. We got polymyositis, we got dermatomyositis, and then we got inclusion body myositis. So three of them. Now these first two are very similar, so we can basically study them together. Okay, these are both chronic autoimmune diseases, so they're more common in women, right? Women. First one is polymyositis. It's got chronic inflammation of the muscles. We're unknown cause. We think it's autoimmune. It's going to affect adult females more than males. And they present with bilateral proximal muscle weakness. So, proximal, hip flexors. What are they going to have trouble doing? Trouble going upstairs. Trouble getting out of a chair. Trouble combing their hair because these muscles are weak. These proximal, they can't comb their hair. They can't get out of a chair. They're all weak proximally. Do you remember Gower's maneuver? They may show you Gower's sign or Gower's maneuver in these ladies because they have trouble getting up. Their proximal muscles are weak. Okay? All right. Now, again, the muscle markers are up. So we're going to do a biopsy here to say what's going on here. When we do a biopsy, we're going to see inflammation in the endomysium. That's the connective tissue around each muscle fiber. So you'll see lymphocytes around each one attacking them. T cells attacking, breaking them down. So we're going to see endomysial lymphocytes. T cells tracking each muscle cell. Yeah, cytotoxic T cells. Yeah, and then you'll see the muscle fibers are degenerating and they're trying to regenerate and they're getting injured again. They're trying to regenerate. That's what we're going to see. Make sense? Okay, so it's a myositis. You might want to treat this with some steroids. Now let's talk about dermatomyositis. Why is this more tested? Because it's very similar to this one, but it also has a rash. So more clues to give you. It's got a rash. Dermatomyositis. Now this is a connective tissue disorder where you get inflammation of the skeletal muscle and the skin. And notice it affects females, but children and adults. So it's a little different because young girls can get this in addition to older as well. Now, same bilateral proximal muscle weakness. Trouble getting out of a chair, trouble going upstairs, trouble combing the hair, Gower's maneuver. But the rash is different. You're going to have rash on the upper lid, so it's going to be all swollen. It's all edematous and swollen, and it's kind of lilac or purple. Purple, red, so they call it a heliotrope rash. That's it. Oh, you're way ahead of me. Heliotrope rash around the upper eye. It's like purple-red. Now, the picture in the notes is kind of red. I don't know, is that purple to you? It certainly looks swollen, doesn't it? This area looks swollen. That eye looks swollen up. Looks swollen, looks reddish, but it's usually a little more purple. But using the upper eyelid, because it could be down here as well. But upper eyelid swollen, this is your heliotrope rash. Very characteristic, wrapping on the upper eyelid like that. Heliotrope rash. You also get in sun-exposed areas too. So you often get it on the chest here as well. Same kind of rash. All right, now when we biopsy this time, because again, the muscles are weak and the markers are through the roof, so when we biopsy this time, what we're going to see is different. This is more of a vasculitis. You're attacking the blood vessels. So we're going to see perimysial, that's the connective tissue around the big fascicle. So here's a group of muscles. On the edges, the connective tissue with the blood vessels, the inflammation at the edges where the blood vessels are. So you'll see lymphocytes next to the vessels. See that? Vascular, next to vessels. So we think basically this is more of a vasculitis. You're attacking the vessels, and therefore the muscles get ischemic. And you'll see perifascicular fiber atrophy. The fibers at the edges of the fascicle start atrophying. They're breaking down. And then you'll see cells that are trying to degenerate and regenerate. They just keep getting injured. They try to come back. Now, patients with dermatomyositis can be associated with cancer. This could be a paraneoplastic syndrome. So let's repeat. If you have dermatomyositis, you have to look for cancer. Lung, stomach, ovary. You got to look for internal malignancies because it can happen by itself, but we've seen it as a paraneoplastic syndrome of internal malignancies. So this is another one of those paraneoplastic syndromes. We have to look for malignancy, but it could happen by itself. Now, for both poly and dermatomyositis, we think it's autoimmune because we find autoantibodies. They're called anti-tRNA synthetase antibodies, better known as Jo1. Jo1 antibodies, anti-Jo1. These are going to be found in both of these diseases, especially when they have lung involvement, because these patients get lung involvement, respiratory, get short of breath. So when they do have lung involvement, they often have anti-tRNA synthetase antibodies, better known as anti-Jo1 antibodies. That's very, if I'm writing the question, I'll probably write about that. That's kind of cool. It's kind of cool. Now, does anybody remember Miley Cyrus? Remember Miley Cyrus, right? Yeah. So this is called dermatomyositis. Dermatomyositis. Now, if you're a TMZ fan, you know that Miley Cyrus was dating one of the Jonas Brothers. I don't know which one, but she was dating one of the Jonas Brothers. Now, apparently, the Jonas Brothers have purity rings, and they don't want to do it. So she's Miley, twerks teddy bears. So eventually she said, "You're not going to do it? Bye." Miley dumped one of the Jonas Brothers. So dermatomyositis is anti one of the Jonas Brothers. If you watch more TMZ, you'll get more points on the USMLE. I get alerts to my email about TMZ. Dermatomyositis, anti-Jo1, anti one of the Jonas Brothers. Okay, feel good? All right, we got to take our last break of the day. We're almost to the end of the marathon. We're almost there. So let's take a little break. We'll come back and we will finish the notes. Guaranteed. All right? I'll see you guys in a little bit. Okay, gang, this is it. This is it. We're gonna finish it up right here and right now. I'm excited to get you guys off to facing this dragon. I want you to face it with confidence, and I want you to rock it. Because we've gone through all the notes now. Your job is to keep going, doing questions, review questions, apply the material, think, figure out how to tell things apart. I think that's the most important things we need to do. All right, now let's finish up here. We got dermatomyositis, polymyositis done. Now we can do this one. This is like the opposite. Okay, it's not females, it's males. They're not young reproductive age, they're older. So this is going to be older guys over age 50, and it's not proximal like the other two, it's distal. So these guys are dropping stuff. They can't tie their ties. They can't button their shirts. This is basically what we're talking about, like distal muscle. So they're like clumsy, dropping stuff, can't tie their shoes. Now, when you do the muscle biopsy, what do you think you're going to see in a disease called inclusion body myositis? Maybe inclusion bodies and inflammation of the muscle? Exactly. So the inclusion bodies are these cytoplasmic vacuoles that are going to have these basophilic granules with amyloid. Yeah, under the microscope, EM, you'll see filamentous inclusions. Those are the amyloid fibrils that you're seeing. All right, so again, kind of lower yield. Just remember, older guy, distal muscle weakness. That's when you pick inclusion body myositis. Okay, now the whole gang photo. Yeah, final stretch. Here we go. All right, now myasthenic syndromes, there are two of them. You got myasthenia and Eaton-Lambert. They're kind of opposites. So if you know one, you'll get the other one right too. So let's start with the first one. Myasthenia gravis, it's an autoimmune disease, the ACH receptor. You wish, you wish, you wish. You're going to have to say postsynaptic muscle membrane, not ACH receptor, ligand-gated sodium channel. What? Yes, it's not antibodies against ACH receptors. It's antibodies against ligand-gated sodium channels. Isn't that evil? They want me to know what an ACH receptor is. Yeah, it's a ligand-gated. The ligand is ACH. Sodium channel. Oh, this is so mean. But now that you know, you'll get it right. Every receptor, they want to know how they work. This is sodium channel. And again, it's postsynaptic muscle membrane. All right, that's what the antibodies are binding to and knocking out. Now, this is going to give you weakness, muscular weakness, usually in the facial muscles most commonly, especially the eyes. So by the end of the day, and they use it a lot, they can't open their eyes, they're getting double vision, they want to sleep because at the end of the day, they're exhausted. So this is autoimmune, so females more than males, and it's the extraocular muscles that are usually involved. So you see the ptosis and the double vision at the end of the day. The weakness worsens the more they use it. Now, if they get a big crisis, the respiratory muscles can be involved, and that could potentially give them pneumonia and death. But that's kind of unusual. Now, let's talk about the association with the thymus. Always look for thymic lesions, thymic hyperplasia or thymomas. Always look for them. And if you see a thymus on the x-ray, you're going to remove it. It's part of the treatment. So we're going to do a thymectomy if we see it. We're going to give steroids and then anticholinesterase agents. This is how we're going to treat it. All right, now let's do the opposite. The opposite would be Eaton-Lambert. Eaton-Lambert is you're making antibodies against the presynaptic calcium channel. Not good enough. What kind of calcium channel is this? What kind of calcium channel is it? What kind of calcium channel? Voltage gated. Excellent. Taiwo, excellent. Perfect. Voltage gated calcium channel. Problem is, what type? There's more than one type. Oh, they're so evil. P/Q type. Don't get mad at me. Google it. You'll see. P/Q type voltage gated calcium channel antibodies. What? Yes. Eaton-Lambert is when you make antibodies against your presynaptic P/Q type voltage gated calcium channels. That's okay. When you see an exam, circle it and say Barone rocks. Who's got your back? Barone's got your back. Google it. You'll see P/Q type. You'll see. You'll see. Active learning, Google it. So for Eaton-Lambert, this is a paraneoplastic syndrome. Usually occurs with patients with small cell lung cancer. Now they're going to get proximal muscle weakness from these antibodies, and it's going to get better the more they use it. So notice it's the opposite of myasthenia. It's the opposite. It's the big muscles, not the small muscles in the face. The big muscles, and they get better the more you use it. The more you use it, the stronger the muscle gets. The stronger it gets, the stronger it gets. So it gets better the more they use it. They're weak in the morning. By the end of the day, they feel great. It's the exact opposite. It's also the opposite because it's antibodies against presynaptic, not postsynaptic. It's against the calcium channel, not the sodium channel. So I think that's really testable, that all these differences. And again, the ultimate treatment is to get rid of cancer. If you get rid of the small cell, these antibodies will usually go away. All right, anything else that I missed here? Eaton-Lambert. I think we got this covered. Voltage-gated calcium channels. Sweet. Sweet, sweet, sweet. They're like opposite diseases. All right, now, oh, wait, I forgot. Proximal muscle weakness means Gowers. So how many things have Gowers maneuver now? What have we just done? Okay, we had dermatomyositis and polymyositis. These were women who have Gowers maneuver. They're weak, proximal muscle. Now we got an old guy with lung cancer, smoker with lung cancer with proximal muscle weakness as well. But what if I give you a young boy with Gowers? Young boy using his arms to get up? Young boy with proximal muscles that are so weak he's got to use his arms? Now you think Duchenne's. So Gowers maneuver is not specific. It just means the proximal muscles are weak. The iliopsoas muscle, the hip flexors, are not working properly. Iliopsoas. So there, and this occurs in a number of diseases, but in boys, young boys, we want to think about Duchenne's and Becker's. These are the two major forms of muscular dystrophy. This is what they do the telethons for. Have you seen the Jerry Lewis telethons for muscular dystrophy? This is the bad one, Duchenne's, most serious one. Now this is X-linked, so it's going to be boys, and it's a rapid progression of muscle degeneration. And the reason for that is the gene. The gene is important for structure. Without structure, the muscles break apart. They literally break apart. So Duchenne's is the most common form and the most severe form of muscular dystrophy. And the gene is called the dystrophin gene. Makes sense. Duchenne's dystrophin. Duchenne's dystrophin. Abnormal growth of muscles. It's on the X chromosome, and it's a large gene, by the way. It's one of the largest genes there is in the body. Now, this protein is very important for muscle structure. They've actually asked, what does it do? What does this protein do? Well, it attaches actin filaments to the membrane. It attaches them to the membrane. It anchors them. So this protein is needed to attach the actin filaments of the muscle fiber to the membrane. Make sense? And what happens here is, unfortunately, without it, now the muscles rip apart. So the more they use them, the more the muscles break down. Notice, no inflammation here. It's not a myositis. This is painless. These muscles just get ripped apart, and CPK will go sky high. Yep, so same muscle markers will be up. You'll have myoglobin, you'll have CPK, aldolase. They'll all go up because these muscles are breaking down when they use them. All right, what kind of mutation? Yeah, it's usually a frame shift or maybe a deletion, but the key is you make the protein and it's destroyed. So it's like a truncated little protein because of the frame shift, and it gets destroyed. There's no normal dystrophin. That's why these muscles break apart when they use them. Just virtually absence of a protein. So this has to be either a deletion or a frame shift. Frame shift is most common. Now let's go to clinical. Clinical. These are going to be boys who are normal at birth because they haven't used their muscles yet. Now by age 5, they're all going to have weakness. All going to have weakness. And it usually is what's called an ascending weakness. So it starts in the calf first. The calf gets weaker and weaker, but it looks bigger and bigger. Why is it bigger and bigger? Because the muscle breaks down and fat comes in. This is fatty infiltration. So the calf looks big, but it's not hypertrophy. It's a pseudo-hypertrophy. It's fatty infiltration. So the calf looks huge, but it's so weak. Then it gets up to your pelvis. When it gets to your pelvis, now you can't get out of a chair. Now you're going to be wheelchair bound. Usually by 10 or 11, they're all in wheelchairs, all of them. Usually by 10 or 11. Now, unfortunately, the heart's a muscle, so the heart can be involved too. So they can get arrhythmias, and that can kill them. Or the respiratory muscles don't work so good, so they get pneumonias and die. So arrhythmias and pneumonias, these are two big causes of death here because the muscles are needed for respiration and for the heart to pump. For diagnosis, the labs are going to show elevations in CPK and aldolase and all the other muscle markers as well. So we're going to do a muscle biopsy because you're weak and your muscles breaking down. When we look at it under the microscope, you'll see areas that are necrotic, areas that are degenerating, areas that are trying to regenerate. Yeah, you'll see fibrosis and eventually fatty infiltration. Fat will replace these degenerating muscles. Now, the key here is we can do immunostains, and we'll see dystrophin is virtually missing. It's missing. It's not there. Missing. Now, these patients can get a confirmation by doing PCR analysis of the DNA. So we can actually look for the mutation in the dystrophin gene. So again, we can stain for the protein won't be there. Then we can confirm it by looking at the gene to see that it's mutated, and that shows you why it's not there. Make sense? Yeah, the heart can definitely dilate. They can get a dilated heart. Doesn't pump. Doesn't want to pump because breaking down. Now, what about Becker's? Well, the rule is Becker's is better. Becker's is better. It's a milder form. It's the same gene, by the way, same exact gene, but it's a mutation that keeps the reading frame. It doesn't shift it. Now, this is an X-linked recessive disease, and it gives you a slowly progressive weakness in the legs and pelvis. Now, it's less common and less severe than Duchenne, so Becker's is better because the mutation mutates the protein, but at least it's made. It's made because the reading frame doesn't get shifted. So therefore, you make it, but it's mutated. It's okay. At least it's there. It works a little bit. So when compared to Duchenne's, Becker's has a later onset with a more variable progression. So here's the rule. If they're still walking at 12, it's Becker's. Becker's is better. So if they're still walking at 12, they're not in a wheelchair, at 12, it's Becker's. And notice, cardiac involvement is rare as well. So these patients can live almost a normal lifespan, but they will get weaker and weaker as they get older. Okay, so Becker's is better. Okay, let's finish up by doing an inflammatory neuropathy. Inflammatory neuropathy, last one. Gower's sign is right here. Gower's sign is when the muscles are weak, proximally, muscles are weak. Right there, the hip flexors, iliopsoas is weak, so they have to use their hands to get up. So the way they use their hands push them up because these muscles won't contract for them. So they got to use their hands to get up. That's Gower's maneuver. It's a sign of proximal muscle weakness. The iliopsoas, the hip flexors, those are the ones that are weak. Gower's. Very good. Okay, last one. Inflammatory neuropathy. Guillain-Barré. This is kind of like the counterpart of multiple sclerosis. Multiple sclerosis, you're attacking the myelin in your central nervous system. Guillain-Barré, you're attacking your myelin in your peripheral nervous system. So we're attacking the Schwann cells here. So again, it's an autoimmune disease where we destroy our Schwann cells and we have peripheral nerve demyelination. Clinically, this is often triggered by a viral illness, or it could be triggered about 30% of the time by bloody diarrhea. Which bloody diarrhea can trigger this? Campylobacter. Oh, they love that. Campylobacter jejuni. Yes. So about 30% of the time, they get Campylobacter jejuni as a trigger. So virus or 30% Campylobacter jejuni. Now, this is going to be a muscle weakness, but it ain't the muscle. Remember, this is the nerves, demyelination of nerves. So the muscles are only weak because the nerves are weak. That's the reason why. So this is an ascending paralysis, the nerves. And one of the big clues is, as compared to Duchenne's, is they lose the deep tendon reflexes. See that? This is nerves. Nerves. It's not just muscle, it's the nerves. That's why the muscles are weak. So loss of deep tendon reflex is a very important clue to tell me this is nerves. Now, another thing we're going to do is nerve conduction studies. And we'll see slowing of the nerve conduction. Without the myelin, you get slow nerve conduction. If you do a lumbar puncture, you'll see inflammation and elevated protein from the breakdown of the myelin. So inflammation and breakdown of myelin, you will see elevations in protein. Now, this is fatal at about 5%. Why? Because the respiratory muscles will just stop working. They'll just stop working, and they can die. Isn't that sad? So sad. It's variable. It really is variable at what age they die. I would say most of the patients are usually dead in their early 20s. Early 20s. Yeah. They don't live much past 20s. Yeah, so wheelchair by 10, usually by 20 they're gone. They're in the ground. Sad. All right, so again, 5% of the Guillain-Barré can die because the nerves don't work, the muscles don't work at all, so they just stop breathing. So they may have to get mechanical ventilation. Mechanical ventilation. Now, under the microscope, we'll see inflammation and demyelination of the peripheral nerves and spinal roots, and that's what's leading to the muscular weakness. Now, a friend of mine, she won a trip to go to Hawaii, so she was really excited to go. So she got on the plane, and while she was on the plane, people were coughing, and she caught something. So she landed, and like the second or third day, she started getting so weak. She went to the hospital, and she had to go on a respirator because she got so weak her muscles wouldn't function. And so basically, she spent it was like 2 months on a respirator, and then as soon as she got better, she flew home, and she said, "I'm never going to Hawaii again." Worst trip I ever had. I mean, that's just terrible, right? Yeah, how awful, right? How awful. Not cool. All right, so it's inflammatory neuropathy. All right, I think we did it. We got this last page of what is it? Tumors. There's a page here of soft tissue tumors and tumor-like conditions. We all know lipomas or fatty tumors. They're very common. You see them in the subcutaneous tissue as well. Now, liposarcomas are malignant. These are bad. We usually see them in the retroperitoneum or thigh. So the rule is for soft tissue to be bad. So anything in the retroperitoneum or thigh is usually going to be malignant, like a liposarcoma, and they're going to have these immature cells called lipoblasts. That's how we diagnose it. Another one that's important, let's see, go down to number 7. Number 7, rhabdomyoma. We actually talked about that. That's like a buzzword. It's a hamartoma. It's a buzzword for tuberous sclerosis. Number 8, embryonal It's one of the most common sarcomas of children. It's a tumor of striatum muscle. Remember the strap cell? Remember the MyoD1, the myogenin, and the desmin? You'll see grape-like masses coming out of the vagina or the bladder or sometimes the penis. Leiomyomas we talked about, smooth muscle tumor, usually in the uterus. You can also see it in the GI tract as well, versus a leiomyosarcoma, which is malignant, usually in the uterus, usually postmenopausal, be a single mass. Okay? All right, the other ones are kind of lower yield. I think we got that covered. All right, so I wish you guys the absolute best of luck. You got my email. My website is down right now. I'm trying to improve it. I'm going to add some stuff to it, so hopefully it'll be up shortly. I'll get my website back up to you guys, but you got my email. I want you guys to be successful. So let me tell you the most important thing. Most important thing. I know this course was like a marathon. You're exhausted. So you need a little bit of time, right? You're going to need a couple days to relax, right? And then I want you to make a schedule. Make a schedule. So I got this much time, make a schedule. Because you'll have structure then. You won't panic. Make a schedule. These days I do this, these days I do this, and every day do questions. Do questions. So I had no discipline. I had to say at 8 o'clock I'm stopping and I'm doing questions because I would never stop. I would just keep studying and I would never use it. So every day you must do questions. Okay? Very important. Then number 2, so make a schedule. Number 2, keep in touch with each other on Facebook, on emails. You got a support system now. People are helping you, and you should keep it that way. Help each other. Like if you make it interesting for what they do, help them get in. Make sense? And then the most important thing is when you take the USMLE, it feels like an anal probing. It feels like a colonoscopy of your brain. It feels horrible. But Roan said it would feel that way. It's okay. You get knocked down, but I get up again. You keep fighting. If you have confidence, you will do great. The second you give up and say, oh my God, I'm failing, they win. They win. It's going to feel terrible. I'm telling you right now. Guy came out the other day. I said, how did you do? He goes, oh my God, if you told me I failed, I'd believe you. If you told me I passed, I would believe you. I have no idea how I did. That's how people feel. And then he got his score back. He got a 270. and he thought he failed. He thought he failed. So the only time you panic is if you think it's easy. If you think it's easy, you're failing. That's the only time you panic. Understood? If it feels horrible, that's perfect. If it feels like anal probing, exactly. If you're tearing up, that's the way it's supposed to be. So you take your break, you go in the hallway, you get your groove back. Come back in with confidence, and you beat this exam. Understood? All right. You can contact me on Facebook. You can contact me on my email. As soon as the website gets up, you can contact me on the website. I'll be available to you guys. I want you to be successful. Just like the rest of the Kaplan team. We all gave you our emails because we want you to be successful. So I want you guys to be successful too. I wish you guys the best of luck. I'll be rooting for you. And I'll be missing you tomorrow night. I may log in just to see if anybody's here anyway. Thank you, Roberto. Thank you, Shalini. Thank you, Tyler. Thank you. Oh my gosh, name's going so fast. Kulsum, Alejandro. Thank you, guys. Harvinder, take care. Take care. Thank you, Eric. Thank you, Eric. Thank you, Dr. Francis. You guys were amazing. As always. As always. Thank you, guys. Take care. Nimit, thank you. Adriana, thank you. Stephanie, take care. Natasha. Natasha. Marine, I can't wait for the new Game of Thrones to start. Taiwo, thank you. Thank you. Mir, thank you, Mir. Bye, Laura. Thank you for your questions. Oh, you're so kind. You bet you say it to all the doctors. All right, I'm going to stick around. Anybody have a question? Anybody have any questions on all the stuff we did? Any questions at all? Oh, you guys know everything now. There's no questions. Man, I'll come every day. Thank you, Louise. Thank you. Thank you, Mir. Appreciate it. Varsity. Christina, bye, Christina. Anchit, thank you. El, El, Elizar, I hope I'm saying your name right. Thank you. Natasha, thank you. Take care, everybody. Have a great night. Have a happy Saturday.